webcast is now starting. All attendees are in listen-only mode.
Good morning. Thanks for joining us today for our webinar. My name is Carmen, and today I'll be your host and moderator. Let's go over some housekeeping items. As a reminder, all microphones are muted and will remain muted during this session. Please use the questions menu to type your questions and comments at any time. Questions will be monitored throughout the duration of the seminar, and time will be reserved at the end of each presenter to address these questions. Slides can be downloaded from the handouts menu. If you have any trouble downloading them, send us an email. This webinar is being recorded and will be available on the Oregon Pacific AHEAD YouTube channel. If you have problems or any comment to share, please send an email to opahec@samhealth.org. To obtain CME or CE credit for this activity, you must log into www.eeds.com and enter this activity code 09BREN. Please consider that the activity code expires in 1 week. We will email you these instructions and the YouTube link later today after the webinar. The presenters and the planners of this activity report that we have no conflict of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. This presentation is jointly provided by Samaritan Health Services, Oregon AHEC, Oregon Health and Science University, and Evergreen Behavioral Health Association. I leave you now for a moment with Robert Fallows, Dr. Robert Fallows.
Thank you, Carmen. So my name is Robert Fallows. I'm the Medical Director for Behavioral Health and Neuropsychology at Samaritan. When I first stepped into this role in February 2020, I saw a massive need for Samaritan to reach out to our community partners in mental health, especially in the areas of diversity, inclusion, and equity. Today represents a year of hard work, and I want to thank our partners at Oregon Pacific Area Health Education Center, especially Carmen Boone, and Intercommunity Health Network, CCO, and Samaritan Health Plans. Without their support, this project would not have been possible. We've had several professionals connect with us and guide us through this work here at SMG as well. And so I want to say thank you to Dr. Alan Silver, Dr. AJ Williams, and Dr. Olivia Danforth for their guidance. Our primary partner in this work has been Evergreen Behavioral Health Association, which spearheaded today's program and first contacted our presenters. I'm especially grateful to Dr. Erica Prince, president of the board, who's going to say a few words about EBHA.
Thank you, Robert. Good morning. As Robert said, I'm Dr. Erica Prince. I'm a clinical psychologist, and I've been in practice in Corvallis about 20 years or so. I'm also the president of Evergreen Behavioral Health Association, and many EBHA members and some of the other board of directors are in the audience today. So they join me in welcoming all of you to this training. There are more than 100 of you out there, so we feel very, very pleased that this has become such an important training for so many people. We are very pleased to have co-sponsored it with Samaritan Health Services and Oregon Pacific Area Health Education Center, and the appreciation goes both ways because Robert Fallows and Carmen Boone have been just amazing in their work putting this together. You may recognize EBHA from when you paid for the training, you were supporting this organization, so I thought I'd tell you just a little bit about it. It's a nonprofit professional association which several colleagues and I started about 10 years ago. We wanted to create more opportunities for community, collaboration, connection, ongoing education about important issues in behavioral health care. So, and besides half-day trainings like today's, we put on more informal presentations and discussion groups. We throw a couple parties each year to get together socially, and we work on projects aimed at community-wide issues such as equitable access to behavioral health care services. Our members are licensed psychologists, social workers, counselors, marriage, family, and child therapists, drug and alcohol counselors, psychiatrists, and psychiatric nurse practitioners who practice in Lynn, Benton, and Lincoln counties. If that describes you and you think you might want to learn more about EBHA, perhaps become a member or collaborate in some other way, you can contact us through our website, ebhaipa.org, or feel free to contact me directly at ebha.president@gmail.com. Thank you so much, and a special thanks to our presenters, whom Robert will introduce now.
Thank you, Erica. Yeah, so it's my absolute pleasure to introduce our speakers today. This is an incredibly important topic, and I know everyone will walk away with not only more knowledge on gender diverse youth, but practical tools that can be implemented in their clinical skill sets. So our speakers today are Dr. Jeanne Connelly, Jess Guerriero, Dr. Laura Edwards-Leeper, and Dr. Danielle Moyer. So Jess Guerriero is a social worker with a second graduate degree in gender and cultural studies from Simmons College. While at Simmons, Jess focused their work on a thesis that argued for the expansion of transgender health coverage and the movement towards therapists as partners rather than gatekeepers in the transition process. Jess has worked primarily with children, adolescents, and young adults who were in some cases navigating medical transitions. Jess is currently working as a social worker at OHSU's Transgender Health Program, helping to improve experiences for community members across the lifespan. Dr. Jeanne Connelly is a pediatric endocrinologist and the medical director for the Dornbecker Gender Clinic, which provides comprehensive interdisciplinary care for transgender and gender diverse children and adolescents under the umbrella of the OHSU Transgender Health Program in Portland, Oregon. She is passionate about improving access to gender-affirming care for transgender and gender diverse youth and is active in local and national advocacy efforts aimed at reducing barriers to care. Dr. Danielle Moyer is an assistant professor in the Department of Pediatrics at Oregon Health and Sciences University within the divisions of psychology and endocrinology. Danielle is a pediatric psychologist and the director of psychology for the OHSU Dornbecker Gender Clinic, which serves the medical, social, and mental health needs of transgender and gender diverse youth and their families. Her work involves clinical service, individual and systemic advocacy, training and education, consultation to medical and mental health providers, and clinical research. In addition to pediatric gender-affirming healthcare, Danielle also specializes in mindfulness and acceptance-based interventions for youth and families. And Dr. Edwards-Leeper, currently an associate professor at Pacific University in Oregon, was a founding psychologist in the first youth transgender clinic in the United States, the first to prescribe puberty blockers to transgender youth. She is currently the chair of the Child Adolescent Committee for the World Professional Association for Transgender Health, is heavily involved in the revision of the WPATH standards of care, and served on the American Psychological Association subcommittee that developed guidelines for working with transgender individuals, as well as Substance Abuse and Mental Health Services Administration committee that created a consensus statement about the harm in using conversion therapy for LGBT youth. She has a private practice outside of Portland, Oregon, where she works with transgender and gender diverse children, adolescents, and adults for therapy and assessment. She also provides consultation and training to providers in clinics around the country and internationally. She is often a go-to source for media outlets, including the New York Times, The Atlantic, The Washington Post, the BBC, and most recently 60 Minutes. Truly honored to have all of our speakers with us today. And with that, I'm going to turn it back over to our speakers.
Thanks, Dr. Fallows. I'm gonna start over the presentation and hand it over to Dr. Connelly. And without further ado, we can start the presentation, the webinar now.
Good morning. Thank you very much for the introduction, and thanks to all of you for being here today. My name is Jeanne Connelly. My pronouns are she and her, and I'm very pleased to be able to be joined by my colleagues listed here on the introduction slide. We hope that you all walk away with some helpful information and skills, and we welcome any questions that you have throughout the presentation or following. Okay, we have no disclosures. We will be discussing off-label use of some medications because still all medications used for gender diverse youth are off-label. I am hopeful that you all have received our slides and a copy of the agenda. This is just a brief framework for the day. We will launch into our context of care section in just a moment, followed by the approach to gender diverse youth by Dr. Edwards-Leeper and Dr. Moyer. Then we'll have a short break. After the break, we'll have medical pearls that I will present, followed by hot topics, another short break, and then we will finish up with our case discussions and wrap up. And with that, I'm going to turn it over to Jess Guerriero to get us started.
Okay, good morning, everyone. Can you hear me okay? Before we launch into the sort of deep dive into working with gender diverse youth, we always like to think about the context of care that youth are seeking care in. And to say that the past, I don't know, pick a number of years, 4 or 6 years have been stressful for trans youth is pretty much an understatement. And for a minute, just picture yourself living somewhere in Oregon or close by to where you live. You haven't come out to your parents yet, and you sign on to Facebook, although I've been told that young people don't use Facebook anymore. Sign on to Instagram, TikTok, maybe you walk by the TV as the news is on. And it seemed like every day for the past 4 to 6 years, there was some sort of negative news headline about trans people in general, and then more recently targeting youth in particular. And I think all of us sort of breathed a little bit of a sigh of relief when the elections happened. But then we saw that state by state, individual legislatures were trying to undermine the progress that had been made around the care for trans youth, and then also youth being able to participate in activities in the same ways that their cisgender peers did. And so that creates at baseline a higher level of stress and a higher level of mistrust of adults. And as we approach this work, we have to really consider that responsibility and how we build the bridge and communicate that not only do we have this knowledge, but that we're mindful of our biases and are actively working to try to change the tide in both our clinical work and in larger cultural shifts. So that's kind of the negative. And as we hold and hear about some of the health inequities and disparities that gender diverse youth face, I think it's also important for us to recognize the amount of creativity and resilience that exists in gender diverse youth communities. They really and truly are changing the face of what gender looks like and what we understand gender to be. And no one's telling them to do that. That is the sort of awakening that is happening. They're building informal networks online in their communities and setting up advocacy organizations. And so there really is a lot of power in the folks that we have the honor to work with. And part of providing this care means opening up opportunities for them to continue to grow and become leaders in their communities. Next slide, please. So that brings us to the context of care in Oregon. And in 2019, the Transgender Health Program and Dornbecker Gender Clinic partnered with the Oregon Health Authority to take a look at underserved populations in Oregon. And we surveyed youth around the state between the ages of 13 and 21. And the whole study consisted of a survey, individual interviews, and then 2 focus groups. We tried to focus on gathering information from folks in non-Portland metro areas, knowing that there's a concentration of services in kind of this upper left corner of the state, and that we likely weren't reaching everyone who was needing to come into care. And so you can see the breakdown of ages and location, and the urban, suburban, rural was self-selected rather than analyzed via zip code. And we did collect most of the information at Portland Pride, so you can see that that the information was skewed in the urban direction, though we still were able to reach more rural communities. And getting into the findings a little bit, as I said, we've known that we're not reaching everyone that we need to reach, and one of the more shocking statistics that came across during these surveys is that 77% of the folks who responded said that they had not seen a provider for help with medical transition. Of course, not everyone wants to seek medical transition as part of affirming their identity, but that's still a pretty staggering number when you consider that our referral rates are climbing pretty astronomically, and there's still so many throughout the state who don't know where to go, don't know how to And in general, about 50% of the folks who responded to the survey said that, that accessing healthcare related to their gender identity was between kind of neutral to really difficult. And one of the reasons we feel really passionate about doing talks like this today is because we want to increase access and decrease the barriers that folks are experiencing trying to get care that they need. In addition to the survey, we also did some qualitative analysis of the open-ended responses and the responses from the focus groups and interviews. And common themes that came up were around provider education needs, as well as, again, the accessibility to services and not having enough provider options in a local area. And again, as we think about our talk today, and you all are sitting in this virtual room here, I hope that you can identify 3 or 4 things that you're going to take with you into your practice to potentially start decreasing the numbers in these particular need areas. We also asked a question about what do you fear most? And I think this gets at that context that youth are existing in. And the influence that politics, society, discrimination, bias has on the awareness of youth. And if you could keep clicking for me, Kara, this continues to blow me away and frankly choke me up every time I think about it. 34% of the youth in Oregon who responded to the survey fear physical violence and death because of their gender identity, because they were outed. And so when I hear parents, when I hear providers say that this is something their kid is doing to be popular or because it's a trend, this is the statistic that hits my heart, to be honest with you, because no one is signing up for something in the face of physical violence and death. And that is the reality of what trans people in general across the country face, and particularly youth are fearful of, even if they haven't directly experienced it themselves. And then related to that, in opposition to that, we also asked what folks enjoy most about their life, and not surprisingly, they answered friends. They are teens and adolescents after all, and we'd be a little worried if that wasn't the response. And friends are a major protective factor for the youth who come to see us and who to, especially in the absence of parental support, their friends and being a buffer at school end up helping them kind of get through their and another strength that our youth community is having a great deal of talent and interest in their creative and special arts. It's really powerful when our young people share their artwork and their creations with us. Proud of the strength that keeps them going. So we want to make sure that we're all starting with the same level of language, and this might seem very basic, so we want to take a little bit of a different approach to it rather than just going through all these terms. And what I'd like to model for you right now is what we call our level setting, and it's something that we do with every family in our class, where a lot of the information might be very repetitive for most families or particularly for young people, but we're trying to translate a little bit to make sure that caregivers and adults are working with the same set of information. And so the way that we model it is to say that gender identity is our own internal sense of self. Gender expression is how we express that to the outside world. And we leave open the possibility that gender identity and gender expression can shift and change over time as someone becomes more familiar with who they are, expands their social circle, and as the culture around them shifts to give them more information about the possibilities that exist for gender identity and expression. And then as someone is considering a transition, they may identify themselves as transgender, which is a larger umbrella term that speaks to the experience of someone whose gender identity does not align with the gender or sex they were assumed to be at birth. Is potentially, did my audio just skip there? I'm sorry. Okay. Non-binary is an identity that is underneath the transgender umbrella or may exist on its own, and it refers to the experience of someone who identifies as or experiences themselves in the world as neither male or female, a combination of both, something outside of, between, or beyond the binary choices of male and female. And as someone considers a transition, we recognize that not everyone is interested in or wants medical care as part of their transition. And it's just as valid for a youth to come in to our clinic to get support and information around exploring gender expression using non-medical options like binders and breast forms or makeup or haircuts. And we provide a safety net by advocating in schools, by talking to parents, faith communities, and just trying to wrap support around any youth who is needing to move forward with some level of affirming their identity. Next slide, please. And that brings us to starting to unpack our social location in this work. And for starters, we all have to recognize that we have a gender identity and a gender expression. Trans youth, gender diverse youth, think about their identity and expression all day, every day. And we often say that we want to work ourselves out of a job so that someone's gender identity is the least interesting thing about them. Unfortunately, that's not the world we live in right now. And as providers, it's important for us to reflect on our own identities, how those show up in the work that we do with folks, and what intersections there are around power and privilege between our identities, assumed or real, and the person who is sitting across from us. And as part of this work, we have to think about the role that trauma-informed care plays in how we approach our care with youth and their families. And the first step is a commitment to trauma awareness and starting to recognize that gender expansiveness exists and starting to think about the way gender has shown up in our lives and how we've been limited or liberated by our own real or perceived gender identity, and how that has led to the beliefs that we may carry about what gender is, can be, whether it's something that someone can alter, or whether we've gotten messages that you are who you are and there shouldn't be any changes made. And even if we're signing up to do this work, that voice may ring loud and clear. And we need to be aware of when it's coming into the room and might be impacting the way that we are engaging with a young person, the questions we ask, and ultimately the care decisions we help guide them towards. It also means that we have to recognize trauma awareness and a commitment to affirming environments needs to happen on individual, interpersonal, and institutional levels. And we'll talk a little bit about that in a bit here. So next slide. Okay. So thinking about the bias and discrimination that folks face, there are many statistics that talk about the health disparities and the negative physical and mental health impacts of experiencing discrimination, stigma, and bias on a day-to-day basis, and the role that minority stress plays in mental and physical health outcomes around education and employment, housing, etc. And again, as we think about this work, part of what we're doing is trying to undo and improve the social determinants of health for our trans youth so that they make it to adulthood safely and successfully. Next slide. And it's important to remember that identity is not illness. Though our folks carry a diagnosis, we need to be careful about pathologizing someone's experience of their identity, and recognizing that in some cases a diagnosis is a means to an end for someone to be able to access the medical care that they need. And the way that identity is formed is impacted by cultural, systemic, and individual factors. And it's not as simple as kind of following the criteria in the DSM to help folks determine who they are in the world. Next slide. And that brings us to the values of trauma-informed care put into action, and thinking about not only personal practice, but how we develop clinics and programs, and then move beyond that into cultural shifts. Next. So in terms of transparency and trustworthiness, we want to be clear about our stance, next slide, stance of practice and the context that we are practicing in, and being clear about the professionals that are involved, the specialties that they represent, what their training might be and experience, and really approaching the care with humility. And again, access is an issue, and I think a lot of people are afraid to sort of jump in because they're afraid of making mistakes. But if you are humble about where you're starting from and what you have to learn, and the responsibility on you to kind of take that on, most folks are going to really appreciate that honesty and transparency. Next slide. And thinking about the potential for interdisciplinary or multidisciplinary care in your work, it's not always possible to have these formal interdisciplinary clinics. And so thinking about how you can potentially incorporate that through consultation, supervision, informal peer networks, and thinking about how each discipline approaches the care and formulating that into a single interaction with a patient or client. And we want to build on each other's knowledge level and experience. Next slide. And empowerment, voice, and choice is a huge sort of tenet of trauma-informed care. And for youth, a lot of times choice is taken away from them because of their age, because of age of consent laws, because they're accessing care under their parents' insurance. And so where we can, we want to create movement and openings for youth to have choice and have their voice recognized in the care that they're receiving. Next slide. And so that brings us to how we at Dornbecker approach care in our clinic. And we demonstrate that we recognize each individual's experience is unique to them, and we don't have a pre-prescribed pathway where someone has to start with therapy and then move to hormones and then move to surgery and then legal transition. We meet people where they are and help them figure out what the next best step is by making sure that the individual patient and their adult supports have the information that they need to make the next best decision and what their individual next steps look like. Next slide. And as we provide this care, we are mindful of what we represent as providers, and that historical models of care really saw transition as a binary experience where there was only two choices, and it was linear, where someone started with a social transition and then moved to hormone therapy and then surgery with no stops in between. There was a sense of paternalism and the need to protect people from themselves, and the idea of doing no harm meant that we as providers somehow had a crystal ball that could predict how someone might experience themselves in the world in 20 years, irrespective of how culture shifts and changes. And care has been shifting away from that model. However, it's still the legacy that we carry with us into clinic rooms. Next slide. And that brings us to, again, that fear, that anxiety that young people might be coming in with. Even if they are naive to medical environments, they've heard the stories in the news, in their support groups, about how interfacing with physical and mental health professionals has historically been a traumatizing experience where people's identities were questioned and they were not able to move on to the next step in affirming their identity because of what professionals in the field said that they were or said that they could access. And therefore, our young people show up sort of with a pressure to conform to our own expectations of binary gender identities when that might not actually be authentic to who they are. Next slide. And that brings us to what we can do. And we need to, again, think about our biases. And above the surface, we have our own professional practice frameworks. We have professional ethics from our different disciplines. There are the WPATH standards of care. And unfortunately, in this country, insurance requirements drive a lot of the care that we provide. And we really need to question where these different care drivers come from or continue to come from. And the recognition that fear of liability plays a role, that we are ultimately sort of applying white cisnormative gender roles upon our young people, and that cissexism is still the default, that people are assumed to be cis until they're not. And then when they say that they're not, they really need to show that their transgender or gender diverse identity is legitimate. Next slide, please. And that brings us to the idea of acknowledging gender expansiveness in the work and really challenging this idea of the singular narrative of born in the wrong body. Not everyone fits that experience, but they feel like they need to come to medical environments saying that there is this sort of tension between their identity and their body, and that they want to move from one side of the spectrum to the other. And it's in the questions that we ask, it's in the literature that we provide in our clinics, and it's also in the way that we frame our conversations that we allow for more rich disclosures and discussions about how youth experience themselves in the world. Next slide. And within the care context, we in order to have empowerment, voice, and choice, there needs to be an environment of safety. And this is where the individual, interpersonal, and institutional practices come into play. Next slide. And what we know is that when youth are supported in their identities, we early, as soon as they say who they are, that there's no elevation in depression, and anxiety is slightly elevated compared to their age-matched cisgender peers, but it doesn't reach clinical levels. And so affirming people in their identities at an early stage can improve mental health outcomes over time. And so we want to think about how we as individuals can affirm someone's identity if other people in their lives are not. And the first step, it might seem simple, but I say this every training we give, this is a small behavior change that truly results in life-saving, as a life-saving intervention. And pronouns and names are really important to our gender diverse youth. And as you can see here, when they're used in multiple contexts, it reduces depression symptoms by 71%, suicidal thoughts by 34%, and suicide attempts by 65%. And when we start talking about suicide attempt rates into the 60th percentile, this truly is a life-saving intervention. Next slide. And safety is created within our clinical environments. If we are providers who do any sort of physical exam, it's important to ask for consent before putting any hands on anyone, even for something that seems as simple as a blood pressure check. Allowing space to explain why you're doing what you're doing and that it would happen to any patient, and then asking permission to proceed is an important step in creating safety. And then think about the different touch points that someone has between calling your office or clinic for the first time and coming to see you, and the amount of opportunities there are to affirm that person's identity, and the amount of potential pitfalls to undermine safety in your environment that there might be. And the last two pieces of trauma-informed care are collaboration and mutuality, and the recognition that that there is a power dynamic, and that as providers we need to work to level the playing field a little bit and be able to have a mutual exchange of ideas, and then thinking about that cultural context that we're providing care in and how that can support or undermine the safety that we are trying to create. And as I sort of described at the beginning with our level setting, the way that we create clinic culture is to offer that to all our patients and families that come through. We also have our pronouns on our name badges, in fact, often multiple ways, both sanctioned by OHSU and then also with pins and stickers and lanyards and things like that. And that becomes a nonverbal sign that we know what we're talking about, and it's an invitation for young people and their caregivers to use their pronouns as well. And then when we introduce ourselves, we always include that in our introductions. And as we provide the care, we really think about intersectionality and not just gender as this singular identity experience, and the role that race and geographic areas play, and multi-generational families, and what youth looks like as a culture in itself. And there's this paradox where we're seeing gender sort of expand and the meaning of gender expand, and at the same time there's often rigidity around what it means to be trans, and a lot of internalized shame about not being trans enough, especially if someone is non-binary, agender, or gender fluid. Next slide. And within the intersectional lens, we think about holistic understanding of health. Again, folks may be coming to our environment saying, I want hormones, I want surgery, but we're actually encouraging them to think about health from a multitude of different directions, and recognizing that medical interventions don't happen in a vacuum, and that they are interacting in school environments, they have an extended family, they may have a faith community, and we need to think about the role that the culture in their family plays, the culture in their geographic area plays, and then our larger societal understanding of gender. And in terms of interdisciplinary care and how trauma-informed care is integrated, our goal is to reduce the amount of times someone has to repeat their story or retell traumatic events. We also want to make sure that there are open feedback loops within our team, as well as between patients and their families and our team, and that we're constantly looking to improve the care that we're providing based on the feedback that we're receiving. And there are often multiple partners that we can draw into the care. It doesn't have to sit within our clinic. And there are many amazing community resources that can supplement or complement the care that we provide to get youth the support that they need. And as we think about entering this work, we have to recognize that part of it means being a clinician activist. Because the care does not happen in a vacuum, and because gender diverse youth are some of the most underserved in the healthcare environments, as well as targeted in larger society, we have to think about how we show up in the schools, in faith communities, with extended family, and thinking about what our sort of professional colleagues or worlds tell us we should be doing, and where we can sort of push the envelope a little bit so that, you know, as a private practice therapist, my colleagues might not get into school advocacy, but if I have a young person that I'm working with who is struggling in PE or is being bullied, I am the support for that person, and I have the knowledge of the medical and mental health impacts of not affirming someone's identity. And so it is my responsibility to step into that arena or find someone else who can, so that eases the path a little bit for that young person. And in the healthcare environment, thinking about trauma-informed care and bringing this all together, we want to walk away thinking about how we depathologize gender expansiveness and gender fluidity. We want to validate someone's self-identified gender and support the youth living in their affirmed gender as they choose to do. It may not be possible for them to live in their affirmed gender right away because of their family system or local community. We want to focus on being less prescriptive and allowing for that richness of conversation rather than a pre-programmed script that youth feel like they have to come in with. And we want to help youth identify and meet their goals, and think about this idea of embodiment and how they experience their gender identity both within their physical body and then as folks are responding to them in society, and what steps they can take to better communicate who they are, and really focusing on how someone can be authentic in this world and in their experiences over assimilating into what they believe being trans enough is, or trying to get as close to cis as possible. All right, and that is the end of my content. So I apologize for the audio issues at the beginning, but does anyone have any questions on what we just covered? We have about 5 minutes before we move to the next section.
Let's see. We do have one question. Just a second. Is PFLAG the right support group for families with gender diverse youth?
Sure. So the question is PFLAG, so historically it stood for Parents, Friends of Lesbians and Gays. It has now been expanded to basically any supporters of LGBTQ plus youth and adults. PFLAG is a great resource. Often often there's a support component as well as an advocacy component to each individual chapter. And they tend to draw sort of a multi-generational group of people, both gender diverse folks themselves, gay and lesbian and queer folks themselves, and their supporters. So it can be almost like a second family. But we also rely heavily on Gender Spectrum, which is a national organization that has some online support groups for youth and their families. And then locally, we refer folks to Transactive Gender Project. They have currently virtual support groups for youth and their families. Wild Heart Society is in Vancouver, Washington. And then there are youth-focused organizations like the Living Room in Clackamas County. Eastern Oregon Center for Living has an LGBTQ support group in Pendleton. Transponder has some groups in the Eugene area, and then there's Rainbow Youth in Salem, in addition to the Portland area SMRC support groups, both on the east side and downtown.
Thank you.
And I can put this, yeah, go ahead.
Yes, if we can share that with the audience via email. If you can give me all those contacts, I'll be happy to make sure that everybody gets them.
Absolutely.
Thank you so much, Jess. Another question, is it true that a youth should be in therapy for 1 year before being in hormone treatment?
No. Sorry, I'll expand on that. Again, this goes back to the idea of individualizing care. We believe that mental health has an important role in the care. We have that obviously integrated into our team with Danielle and with myself. However, having a specific length of time that someone is in therapy is not as useful as having conversations with youth about how they experience themselves in the world, what their support systems look like, what their goals look like in the future. And, you know, a year in therapy can look very different from person to person, and what someone gets out of that it might not necessarily be such a positive experience if they know, like, oh, I have to show up and perform for a year before I can move on to the next step. So we really focus on what each individual's psychosocial needs are, and then make recommendations accordingly about whether their mental health needs can be supported within our clinic, or whether there is an outside provider that would be a better connection for them for ongoing work. And then the provider and the youth themselves determine what the goals are and when that person has met those goals. And some people stay in ongoing therapy throughout their transition. Others seek other types of support to affirm their identity, explore their identity, and those are just as valid. These support groups that I named are often where some of the most authentic conversations are had, and where resources are exchanged, and then we can kind of step into the more, I guess, professional role of mental health support as needed. Danielle, I don't know if you want to add anything to that based on our practice.
No, I think that was a great summary. I'll probably expand a little bit during my section. So this conversation is one that we have a lot, and it will continue throughout the presentation.
Thank you so much. I think right now we are running out of time. So we're gonna keep those questions until the end. And please keep, no worries. We'll make sure to answer all your questions. If there's no time, we'll answer them by email. Anyways, you'll get an answer. Now I'm gonna switch the screen to Dr. Edwards-Leeper. And just really quickly, Dr. Connelly, just a reminder, if you could check those boxes. Thank you so much. All right.
Okay. Can you see my screen?
Yes, it's working perfectly. Thanks.
I have to figure out how to make, wait a minute, I can't see my screen. I see myself. Okay, I'm gonna move that over. All right, I think this is gonna work. I'm not as familiar with using WebEx as Zoom, so it's always a little bit tricky, but all right, well, thank you so much for everyone being here and for the invitation to participate in this. Oh wait, hold on, things got moved around all of a sudden randomly in my screen.
We are able to see your screen. Right now we're seeing the first slide that has the title.
Okay. Yeah, okay. I just need to, that's for some reason it made me look really big on my screen. Okay. I think this is, I've got it okay now. All right. So I'm Laura Edwards-Leeper and I use she, her, hers pronouns. And I'm going to dive right in because I don't have a whole lot of time to talk about, we all have so many things that we could go on and on, I think, for many hours about, but I'm going to be covering, hold on, oh wait, I'm sorry. It's like my screen is really causing me a problem here. Okay, just can't see all of it. Okay, I'm going to be talking about early childhood care and social transition, and then dive into very briefly a little bit about assessment. All right. Okay. Except I don't know. Can you remind me how to advance my?
If you can just click on the screen.
Oops. Oh, there. Okay. It worked. Okay. Sorry, again, it's different. Okay. So to start off, I'm going to be talking just briefly about younger kids, so prepubertal children who are gender diverse. And the two big questions in the field currently include, does gender dysphoria persist in childhood? And also, is social transitioning for young children recommended? Those are kind of the big topics that a lot of people are debating these days. To start off, we have to kind of ask ourselves the question of what the likelihood of a gender dysphoric child later identifying as transgender is. And the research on this is kind of complicated, but I think it's worth just mentioning what we do know at this point. As you can imagine, we don't have good research on this, in part because in order to really study it, it requires very long longitudinal studies. You know, we have to be able to follow kids for many years. And so that makes it difficult, you know, because we haven't really been tracking gender diverse kids for very long. But the handful of studies that do exist show that about 20% of gender dysphoric or gender diverse children will persist in an identity that's not cisgender, and the remainder will what is often called decis, meaning that they won't continue in that way. But the range, depending on the study that you look at and sort of which exact population the researchers were looking at, ranges from 12 to 50%. So the 20% is sort of just the number that's often thrown around, but you kind of have to take it with a grain of salt. So the other thing that's really, really important about all of this is that we can't predict an individual child's gender trajectory. And so these are all the different ways that things may progress for a kid. So it could be that this is, you know, their gender, the dysphoria, diversity, whatever we want to call it, is one chapter in their gender identity journey, and their path may go a lot of different directions as they continue to grow. They may identify as gay, lesbian, bisexual, some other non-heterosexual sexual orientation later. And there is quite a bit of research that actually does show a connection between early childhood, gender non-conforming interests and behaviors and that sort of thing, and later sexual orientation. And the reason that's important to note is that when parents come in with young children who are gender diverse, we don't want to just talk about the possibility that their child may be transgender, but also that their child may be something other than heterosexual. And that, you know, sometimes for some parents, that is also difficult for them to grasp and to consider. So it's important to be aware of that. It's also possible that the kid may just always be a more masculine girl or a more feminine boy, but never actually transition to a different gender from what they were assigned. They may identify more as genderqueer, non-binary, agender. They may perceive their gender as fluid. They may transition socially, but not physically. Or they may strongly and persistently identify with a gender different from what they were assigned and pursue social and physical transitions. So there's a lot of different paths that it can go. Some of the, just very quickly, methodological concerns in the early research that I think we have to talk about if we're going to talk about this research include that when the researchers looked at these kids at the beginning, they were including in the DSM at the time, gender identity disorder not otherwise specified, in addition to the straight, like more severe cases or extreme cases of gender identity disorder. And so we would expect, given that a lot, that there would be a higher rate of kids who would desist. The other kind of major problem, it was that they used medical and physical transition as the outcome variable, or to kind of see, how many kids actually did persist. But we now know that not all trans individuals can or choose to pursue medical intervention. So that's really not a good outcome variable. It's kind of is problematic. Another criticism that is often brought up with this research was that the adolescents who were lost to follow-up in the study, like they did not return to the clinic, were assumed to have desisted. Now, that would be a major problem if that were true, if the researchers actually just kind of ignored anybody who never came back to the clinic and just lumped them into the desisting group. It turns out that, and this is a problem, but it turns out that the researchers actually did follow up with the people who didn't return to the clinic. They got through to almost all of them, I think, except maybe not, there were like a handful that they couldn't find. And the people that they did, that were lost to follow up, did in fact desist. So they were correct about that. Why they didn't include that detail in the study, I don't know, but having spoken with the researchers directly, I can safely say that. So that part we don't have to worry about, but the other two issues are concerns. More recent research and clinical experience suggests that young kids with more severe gender dysphoria in childhood, and again, I'm talking about, the prepubertal, like elementary age kids, those kids, if it's more severe, like if this is a kid who's saying, I was born in the wrong body, God made a mistake, why did, mom and dad, you made a mistake, or whatever, parents, you made a mistake, those sorts of kids who really reject their assigned gender we are finding that they're more likely to persist than the ones who aren't so insistent about it. The other thing that the research has started to show is that as gender dysphoria and cross-gender identification persist and intensify into adolescence for these little kids, the likelihood that they're going to fully transition seems to increase. So both of those things seem pretty obvious, but we now have, there's a little bit of research now to actually support that. Even given all that, though, we have to remember that every case is unique and we can't predict an individual child's gender trajectory. And so that's the most important thing, I think, is just to stay open to whatever path the child ends up going. So again, briefly, I'm just going to talk a bit about the 3 different treatment approaches for working with kids that have been used over the years. The first one is working with parents to decrease cross-gender behavior and identification. This, I'll just say before I even say anything more about it, we do not recommend. This was used in the past some, and probably some people continue to try to use this now, although this is typically considered to be conversion therapy, is what we call it, which is not helpful and actually can be quite harmful to kids. And the idea with this would be, like an example would be to just, if you're working with an assigned male at birth child who wants to wear dresses and play with dolls, as the therapist, you would be recommending to the parents to not allow the child to do that and to instead buy them trucks and get them signed up with Boy Scouts and kind of male-gendered, stereotypical male-gendered types of things. That is not a good idea. So we don't do that. The other 2 approaches that are used include allowing the kid's gender to unfold naturally, A lot of the work with this is helping the child and the parents prepare for any social risks as this happens. Sometimes this is called the wait and see approach because it doesn't necessarily involve a social transition. But then sometimes for some kids, you know, moving forward with a social transition is a really helpful thing for them. These number 2 and 3 actually really overlap a lot. So very rarely do I know of a clinician who just does the wait and see approach or who just does, you know, like any kid that comes in, they're socially transitioning. It's much more individualized than that, but those are the 2 more common approaches these days with the younger kids again. So in terms of the pros and cons of social transition, and social transition meaning just the child maybe changes their name, changes their pronouns, changes their gender expression, which is like their clothing, their hairstyle. You know, the parents start referring to them as their daughter instead of their son, those kinds of things. And by the way, there's variability even within social transitioning. I've had some little kid clients or adolescents even who, you know, maybe want to change their name but not their pronouns, or they want to change these things at school but not at home, or vice versa. So there's a lot of variability. But some of the pros that those of us doing this work see is that by allowing kids to do this when this, you know, really seems like the best thing for them, it can really, well, it affirms their identity, and then that often, you know, almost always, I would say, decreases emotional distress that they're having, improves their mood, improves behavioral problems. It can greatly increase their confidence and self-esteem. And it allows the kid the opportunity to experience socialization as their affirmed gender, which, you know, we could argue, well, is that really a good thing? It just kind of perpetuates the binary. And so I think that is a really valid point. But at the same time, the reality is we do live in a society where, you know, there is a gender binary, and working with a lot of trans adolescents and especially adults, one of the things that they really struggle with and wish that they would have had the opportunity to do is to kind of learn those early, like those social nuances and skills early on of how to interact and sort of kind of be a girl or be a boy in society. So by doing this at a younger age, you know, kids kind of learn all that just through living that way. And as Jess, I think, mentioned, recent research also suggests that trans youth who are supported by their parents in an early transition have no greater mental health concerns than their cisgender peers. So, you know, the little bit of research that we're starting to get from this group is really showing, you know, very positive outcomes, at least in the shorter term. Some of the cons include that, for one, childhood gendered identity is often fluid. So, you know, how a kid is identifying at one moment in time may not predict their future identity. That's fine if the child feels free to change. And I definitely have kids on my caseload who have socially transitioned, and I talk with them about, you know, do you feel like if you ever changed your mind, your parents would be okay with you changing back, and how would that be with school and your friends? And certainly there are a lot who absolutely feel supported in that way, especially in places like, you know, Portland, or, you know, more liberal areas where the schools, like the whole culture is kind of just supportive of gender diversity. But I also have clients who live in, you know, like Southern Oregon or other places where they've made a social transition. No one at the school knows that they're trans, actually. And, you know, I do think that it would be hard for them if they decided that they wanted to take a different path, because just things are a lot different in terms of how people understand gender in some areas. So committing to a different gender at a young age can make, in some cases, could make the kid feel boxed in, could be difficult to switch back. And so my message that I relay over and over to parents is we just had, well, actually parents as well as teachers, providers, like all the adults in the kid's life, that we really just have to stay open to whatever the direction the kid wants to go. And then, as I said a minute ago, another potential con of early social transition is it kind of perpetuates the gender binary, which a lot of us are trying to move away from, because, you know, we're basically, you know, kids are kind of feeling like they have to choose one or the other a lot of times, as opposed to just being able to be a kid and sort of not have to think so much about gender. Okay, so that's all I'm going to say about the little kids. I'm now going to shift into just a very quick overview of assessment with adolescents. And this is something that I often will give a 2-day training on. So doing like 15 minutes is really going to be a super, super quick overview, but I think it's important to just touch on some of the highlights. To begin, it's really critical to understand about the different models of care, first in the adult world, because that's really, you know, historically, that was really just adults that we were dealing with when we were, you know, helping people in the trans community. And historically, what was used was more of a gatekeeping model of care. And this was really not helpful and actually quite harmful to a lot of trans adults. This required mental health evaluation to determine if a medical intervention was appropriate for the patient. And it really was kind of like a test, like it, you know, it was the provider was seen as the authority. And as Jess was talking about earlier, you know, the patients would have to come in and sort of prove that this was who they were and they deserved to be able to move forward with the medical interventions. Fortunately, we've moved away from that. And so most places these days do what's called an informed consent model of care. And the goal here is really to decrease unnecessary barriers because those are often seen as paternalistic and gatekeeping, and really giving the patient more autonomy to decide what medical interventions they need. And so that is absolutely, I think, appropriate and the way I approach all of my work with adults. With teenagers, however, a lot of people feel, and the WPATH standards of care strongly recommend more of a developmentally informed consent model of care. So it's a little different than what we use with adults. And this needs to involve mental health support and assessment, parent involvement whenever possible, and really just a recognition of how complex adolescent development is. And that, you know, for any of you who, you know, are trained to work with children and adolescents, I mean, this is kind of like a no-brainer. But, you know, I think sometimes that gets lost in the conversation around trans youth. We kind of sometimes forget that, oh, you know, these are teenagers and we do have to take that into consideration. So the assessment, the other thing about this that's, you know, kind of, I think has taken me off guard a little bit as a psychologist, where assessment has always been considered a really useful tool and something that helps us develop an individualized treatment plan for all kinds of mental health or medical conditions. Because of the historical trauma and the gatekeeping that's happened with trans adults, I think largely, assessment has really come to be considered very negative in this population. And so a lot of people, you know, feel that this, well, I don't know, I shouldn't say a lot of people. There are people who sometimes feel like this is not really necessary and actually can be harmful. Whereas again, you know, as psychologists and other mental health providers, often, you know, we kind of see this as a very useful tool and can kind of help guide people on the path that's going to be best for them by just providing more information and getting a more holistic understanding of the individual kid. So there are some variations in how these assessments occur. The most comprehensive, which is really the only approach that's been studied with research, is a multi-method, multi-source process where there is both therapy and a more formal structured assessment, which includes the use of psychological and gender measures, feedback session, a report, kind of like other traditional assessments that are done in the mental health world, psychology, I guess, in particular. A somewhat comprehensive approach would be where there's maybe one mental health assessment that either occurs over the course of several visits with the parents and the youth. This is what a lot of social workers who I've trained do, because they can't bill for kind of psychological testing, but they can bill for multiple visits. Or it could be one longer comprehensive evaluation with the parents and the youth and just kind of get it all done at one point in time. And that's one thing that I do quite a bit of. And then slightly comprehensive would be one brief mental health assessment, just one visit with a mental health provider at a clinic or with a provider in the community, and it would just be kind of a quick overview of things that, to get a sense of what the kid was wanting. And then not comprehensive would be no mental health involvement and just jumping right into medical intervention. And very few places do that these days. In the adult world, it's a little different, but with youth, most clinics do at least a slightly comprehensive assessment. So in terms of the comprehensive assessment, I'll just say that anecdotally, what I've heard over the years, I've been doing these since like 2007, I guess, it's very positive experience almost always. So, and part of this is because it really gives voice to the kid and the family. People really like to tell their story. Parents really like to share their experience and sort of their concerns, but also sort of what they've seen over the child's life. A lot of these youth really like talking about, their gender identity development and just everything else about who they are. It really often, I can't tell you how often it decreases parents' fear about moving forward if that's, the best thing for the kid and, how to best support their child. That's been one of the coolest things, is just to see the transformation in parents through the assessment process. It also offers an individualized, holistic approach to understanding the kid. Many, like I said, many are very appreciative of this. And in the last several years, I've started to offer this for young adults who want it. Some of them actually come to me requesting it. It's not something that I say they have to do, but it's been surprising to me how many young adults actually want a more comprehensive approach. So the bottom line is assessment absolutely can be supportive and affirming if it's done in a collaborative and supportive way. And I don't know of any research that suggests that this process, when done this way, is traumatic or pathologizing. So the critical areas to cover, and this is the part that in my 2-day training I go into great detail about, but obviously we're wanting to understand gender identity development, how and when the dysphoria came about. Was this like early, like when the kid was young, versus later? It is important to understand possible influential factors, and these can be positive and negative. So it's not uncommon for kids to find information on the internet, and it's the first time that they were able to put together this feeling that they've been having for so long and to actually have a name for it. But there's also situations where kids are influenced by their peers. That's no surprise. Teenagers are very influenced by peers. And so sometimes there can be pressure from like societal pressure or social media that can be influential. And it's important to really get a handle on that so that we help the teenager articulate their journey, their own story, and be able to really think about what's best for them. It's important too for kids to understand that there's a lot of different ways of being a boy and a girl, and to assess to make sure that they're not getting confused, thinking that the only way to live the way that I want to live is to physically and socially transition to a different gender, but that there's a lot of different ways to live in your gender. It's also important to assess the intersection with other aspects of identity development, such as sexual orientation. These are different constructs, and in Trans 101 trainings, I always tell the audience, sexual orientation and gender identity are entirely different things. But when the reality is that there is some overlap, and it is, in terms of gender identity development, it's not uncommon for people to be thinking about their sexual orientation at the same time that they're thinking about their gender identity. And so it is important to sort of help young people sort out, what exactly is going on for them in that area too. Transition hopes and expectations are critical to assess because we want to make sure their expectations are realistic. A lot of them do get their information online, and so it may or may not be accurate. Assessing family dynamics and support, family psychiatric history and medical history, all of this stuff is information we would gather in any comprehensive psychological assessment. The way that I do it, though, the structure I've created ties in a lot of gender pieces to each of these categories, and that's what I don't have time to get into, but just to let you know that there's a little bit more than just the basic family psychiatric history and family dynamics, etc. Social dynamics and support, school education and history, functioning and support, medical history briefly, developmental history, significant events in the kid's life, We obviously want to know about abuse, trauma, teasing, bullying, and then a comprehensive diagnostic mental health assessment is one of the bigger parts, because a lot of young people coming in do have mental health issues that we need to understand and make sure are being treated, and also make sure aren't complicating the gender picture. This should go without saying, but unfortunately it does not always go without saying. And this is one of the messages I shout loud and clear many times to my graduate students, that if you're a child or adolescent provider, parents and caregivers should always be heavily involved in the assessment process, unless it would do harm to not include, to the young person to not include them. And that's nothing new. That's just, you know, the way we always approach it. But for some reason in the trans health world, I hear many times that parents feel like they're left out of the process. Parents have a very valuable perspective that we really need to consider and hear. And we know from research that kids do best, trans youth do best when they have the support of their parents. And the best way to get the parents' support is to involve them. The current WPATH standards of care, which is version 7, has these 4 criteria. The revision of the standards of care is nearing its completion. This has been a multi-year project, and those of us involved in it cannot wait for this thing to get published, because it's been a huge amount of work. I'm not allowed, unfortunately, to say much about it at this point because it's not published yet, but they're hoping by the end of the year. But I would say at least by early next year, it should be published. But the 4 main criteria, kind of overarching criteria in the current standards of care for youth pursuing medical interventions, is having clear gender dysphoria, no complicating mental health concerns, supportive parents and caregivers, and the ability to give informed consent. And there are quite a bit, again, that goes into each of those, but I don't have time to get into all of that right now. Okay, the few more things quickly. Research that shows the positive outcome for gender dysphoric youth who've received medical intervention include 2 components, and this is important to remember. So there's one study basically that has shown very positive outcomes for youth going through the medical transition process. But all of the kids in the study had childhood gender dysphoria. So none of the kids in that study were kids who came out when they were adolescents. Also, all of the kids who were in the study went through a gold standard assessment process, which meant a lot of therapy, at least a year of therapy, and a structured assessment. So there, I mean, that's the reality. It does not mean that we should not be treating young people who don't have childhood history or haven't gone through that gold standard assessment. The reality is most of the adolescents we see don't meet either of those criteria. So we are certainly moving forward with intervening, and it's important that we do that. But it's just important in the informed consent process that the youth and the parents know if they fall in this kind of different category, that we really don't have research to guide us at this point. We're using kind of our clinical best judgment, which is fine. That's what we have to do in an emerging field. But parents, in my opinion, need to, and the youth need to know that. We don't have any long-term research on youth who defer in one of these areas above. But we are assuming that most, I would say probably most youth are doing okay. But we also can't ignore the fact that there are detransitioners, people who do change their mind, and those individuals, unfortunately, are often lost to follow-up. A study that just came out this last week, which is very informative about some of this, found that 55% felt that the assessment process they went through was inadequate. Now, one beef I have with the study, I need to read it a second time, but it's not clear to me if these were young adults which would make sense if there wasn't a big assessment because of using an informed consent process, or if these were minors that felt like they weren't being adequately assessed. But nonetheless, a lot of these young people are lost to follow up, because they're not uncomfortable going back to their clinics. They have a lot of shame around it. So we don't know much at this point about people who do change their mind, and that's obviously an important thing for us to study further. Okay, and so I have to wrap up. I think I'm on my last couple of slides just to say the goals are to give people the information they need, help the young person thrive. And these are some of the challenges. that we have in doing assessments. A big one is just there's so many youth who need treatment and we don't have enough providers. Hospitals also don't have a lot of the resources they need for enough mental health people. And the feedback is positive. And very last, actually that's the last slide. So there you have it. Sorry, I don't know how to go back actually. So I'll just leave it at that.
Thank you so much, Dr. Edwards-Leeper. I'm gonna hand these so Dr. Moyer can start. Just a second. There we go.
Okay. Can you hear me okay? Great.
Yes, it works great, and we can see you great, and slides too.
Okay, awesome. I'm going to build off of what Dr. Edwards-Leeper is talking about and sort of integrate it into our interdisciplinary approach to care and how we like to take a multidiscipline approach to this work. Next slide, please. So just to give you some background on what interdisciplinary care even is. So historically, we've had behavioral health co-located with medical professionals, social work, psychology, endocrinology, nursing, and sometimes those are in the same location, and so that's great. Like, salad's good. This salad looks particularly good. But over time, we've learned that there are actually slightly better ways to do this type of care. Next slide. So when you think about a multidisciplinary healthcare systems, that's where the ingredients start to get a little more integrated, like a lasagna, where you can still see the individual components of the pasta and the cheese and the sauce, but they inform each other and can help to be very delicious, better than salad. But in an interdisciplinary system, it looks a little bit more like cake. So all the individual ingredients are integrated in a way that looks like a different thing. And when I talk about the way that we approach this work, you'll see how we sort of integrate ourselves in a way that we're not just giving our own expertise, but combining it in a way that produces the best outcome. So we think we're cake. So our approach is a patient and family-centered one that we continuously evaluate through QI processes or quality improvement, where we have multiple points of intervention, psychoeducation, and evaluation. And we continuously normalize the evolution of somebody's gender identity over time. And then in a moment, I'm going to go into more detail about the shared decision-making that we use to guide our youth to the next best decision. We discuss non-medical options with as much validity as medical options, and we follow our patients very closely as they do explore any medical transition options. We allow for changes in course as needed. As Dr. Edwards-Leeper pointed to, not everybody stays on the same course throughout their lifetime, so we make space for that, especially our expanding group of non-binary youth who are trying to figure out what that means for them. We provide information in a developmentally appropriate manner. And the goal is to make sure that our caregivers are equally prepared as our youth who have sometimes come in having done a lot more homework. So the role of the mental health professional on the team, or like my role and Jess's role, we can help a youth explore their goals for transition. We can address shifts in any social experiences or mood as medical transition progresses. We can, as behavioral health professionals, we are trained in development and we can provide developmental perspectives to the other team members. And then one of the most important things that I find in my role is really providing parent and family support, because this can be harder for parents and caregivers than it even is for our teens, and that's an important component of this work. So just to touch briefly on pathways of development, we know that gender developmental milestones, and by that I mean when somebody first recognizes their gender, when they first come out, those sorts of things, their experience with their primary and secondary sex characteristics, and their desire for gender-affirming medical interventions vary across individuals. Even the awareness of a gender identity is incongruent with the gender they were assigned at birth can come out at different times. Yeah, you can go ahead, Karen, skip ahead till we can get all 4 on here. So I'm just going to talk a little bit about the common pathways. As Dr. Edwards-Leeper mentioned, a lot of youth identify as gender variant in childhood and do not go on to identify that way in adolescence or adulthood. And then, of course, and you can see this line for puberty because I like to give people an idea of the sort of 4 common pathways. These are not the only pathways, but they're just the common ones we found. There are children who identify as gender variant in childhood and go on to persist into adulthood and adolescence. And as Dr. Edwards-Leeper mentioned, that tends to be those who do have an increasing severity of their gender dysphoria or sort of more significant gender nonconformity, but we cannot predict who exactly that will be. And then we have these second 2 groups that are folks that tend to not come out until after puberty. So one of those groups tends to be those that do recognize something different about their gender identity early, but don't have the space to come out or don't have the distress that is high enough to come out until they hit puberty, and those changes cause them distress. And then there's a group of youth who don't recognize their gender identity until after puberty. Often the onset of puberty can be that that prompt for them. Now, of course, not everybody comes out right at puberty, you know, depending on your social situation, how accepting your environment is. We know that some people don't come out until their 60s, and that's, you know, a pathway as well. But in terms of young people, these are the 4 most common pathways we see. And then we in our clinic always make space for the potential to change course even after puberty, of course. As was mentioned, there are people who decide to stop gender affirming care or to go back to living in their gender assigned at birth. It's a small percentage after puberty, but there is a group of people. Some of them feel more aligned with the gender they were assigned at both. Some of them feel like even after they've transitioned, they don't fit in their communities, are still not accepted by their families or religious environments. And then others feel like surgeries didn't do what they expected, or they had unrealistic expectations for how those outcomes could come. This research is predominantly in adults, so it's a little bit harder to sort of generalize to our youth. As mentioned, we need to get more longitudinal data. In our clinic, what we tend to see is more often adolescents are taking hormones, for example, for a period of time until they achieve what they are desiring from them and potentially stopping at that point. And I think this is a lot to do with the way that we're expanding care for more non-binary identities and folks who want to do shorter term courses of hormones or low dose hormone use that doesn't do as much of the changes as with the traditional sort of regimens that Dr. Connelly will go over more in her section. Next slide. But it's actually way more complicated than just, you know, those 4 groups and puberty. Research has shown that gender identity development is influenced by a whole host of things. And I know it's a busy slide, so you don't have to feel like you need to read it all. But some of the things that go into it are what supports exist in a youth's life, how their family adjusts in general to change, have they seen any peers come out, and what the reactions have been from those people and their families. Their particular experiences with puberty and how those things relate to them, stigma, cisnormativity in the world, all of these things come together, and so gender development is really a process that has a lot of factors. A lot of parents come to me asking about, well, how can adolescents know anything about anything? And I agree that they have some brain development left to go, but there's a lot that adolescents are figuring out about themselves. And the first thing I try to help families understand is that gender identity is a developmental process. It's not a decision. Some parents will say, well, how can they make this decision? It's going to impact the rest of their life. And to that I say, well, there are care decisions that we can make. There are medical and non-medical interventions that a person might want to pursue, and those will make decisions. But the gender identity itself is not a decision somebody makes. It's a developmental process. We also help them understand that decisions not to pursue certain social or medical interventions are not neutral and have their own risks and benefits to them. A lot of parents ask me about impulsivity and peer orientation, which of course are things in adolescence. I will say that navigating the American healthcare system doesn't tend to be an impulse. It's actually very complicated and hard to access, and sometimes takes years with wait lists and everything. But that doesn't mean that I don't think that impulsivity is important to think about. And in fact, I think about it in terms of what kind of impulsive things might an adolescent do if they're feeling rejection from those around them? How are they going to be influenced by their peers if they don't feel like they can come to their family with things? So those are important things to think about, but not just in terms of what we're doing to affirm someone's gender. And for that reason, we think that when possible, a team approach that involves, the family and providers together is the best approach, and as much as we can integrate and collaborate with other providers, the better. Next slide. So shared decision making came out of the patient-centered care movement, where there was a shift from provider-centric to patient-centric care, and it fundamentally believes that self-determination and patient autonomy are important. And there have been lots of formal decision aids created. If you haven't been to this website, jot it down because it's very cool. Everything from how to help a family decide if their kid should get on ADHD medicine to whether or not an adult should get knee surgery. There haven't been formal decision making aids for this, what we're talking about today, but that is my hope and dream for the future. So one of the challenges, or there's several challenges with shared decision-making in youth. First of all, we're involving youth, and they are not a singular unit. They are a family system. They come with parents. The legal age of majority might differ from the age of consent. So in Oregon, our legal age of medical consent is 15, and the age of mental health consent is 14, and that's different from the age of majority. And some states have mature minor clauses that are similar. The American Academy of Pediatrics suggests that adolescents, especially those 14 and older, should be involved in their medical care. And then thinking about, is there one parent, one caregiver involved, two caregivers? Is the state sometimes involved in care when somebody's in CPS custody? Those are all complicated factors. Next slide. So this is sort of the traditional shared decision-making, like Venn diagram, that's the word I'm looking for. So the clinician comes in with expert guidance, professional experience, clinical evidence, therapeutic goals, and the patient comes in with their own lifestyle and values, treatment preferences, and personal goals. And I do want to say that shared decision-making is predominantly used for care decisions that there are multiple options, and each option can have different risks and benefits that can be of different value to different people. So if it's something where the sort of risks of not doing something far outweigh the benefits, or vice versa, so this is not necessarily always the course, but this is a complicated for complex decisions. So to complicate the picture a little bit, we have at least one caregiver with our adolescents. Next. Often two caregivers. Next. Sometimes clinicians represent a variety of disciplines like medical, psychology, social work. There might be other, especially in certain cultures, there might be other family members who are important decision makers. We all hate it, but insurance drives a lot of our decisions. Sometimes our individual institutions have certain rules that play a role. And then finally, the broader community and advocacy groups that exist and how they play into the decisions we make. So it's a much more complicated system. There's a lot of different models out there. I just kind of synthesized them into this 4-step process that I'm going to go through. So step 1, seems simple, but it is to identify that a decision needs to be made. Sometimes that isn't clear to people. And we always include the option of doing nothing. So for example, if a teen wants to start hormones, the decision might be, do we start hormones now? Do we not start hormones with no plan to? Do we start hormones at a later predetermined time? And that can be arbitrary or non-arbitrary. So an arbitrary predetermined time, some parents say, well, they can just do it when they're 18. And I try to talk to people about how arbitrary time limits can sometimes cause despair and hopelessness and a lack of agency, so it's not the best. But there's also non-arbitrary predetermined times, like when a youth has been able to articulate exactly what their goals are, or when a family has been able to get enough education. So those might be all the options that we list. And then clarifying that these, like I said before, these are decisions related to care, not necessarily about somebody's gender, and then identifying all the individuals involved. And this process, again, can be for any medical condition, but I'm applying it now to gender affirming care. Next. So then the step 2 is to provide the information. So describe, what gender dysphoria or trans identities, we do our level setting that goes through all the different definitions. We talk about all the options, describing the positive and negative features of all of those options, including doing nothing. And then when we can, including the chances of positive and negative outcomes. Next slide. And then, really acknowledging the role of emotions, having folks imagine the physical, emotional, and social effects of something, eliciting which features are most important to a family, clarifying similarities and differences. So for example, I have one measure that I give that is was developed to assess attitudes and beliefs about fertility. And there's a paired measure. One is for parents about their child, and one is for teens about their own experience. And they're the same questions, just worded a little differently. And we can compare and contrast what things people find similarly and which things they don't, what they differ on. And that measure is super useful because sometimes people say out loud that they have very different ideas about fertility. And in my experience, measures show that families tend to be much more on the same page than they think they are. It's just one example. Next. And then again, it seems obvious, but making an explicit decision, because the decision not to do something is also a decision, differentiating whether someone's leaning towards something versus having made a full decision, explicitly naming any unresolved decisional needs, and providing clear next steps. So I'll talk a little bit about how we do this. So every patient that sees us has a dedicated intake call with our social worker, Jess, and at least one team visit with medical and behavioral health together. And then sometimes they see me separately, and sometimes they see the endocrinologist separately. So at the intake, Jess will elicit child and caregiver goals and expectations. You'd be surprised how often people come into that intake not even knowing what each other are thinking yet. Starting to introduce the pathways of care and potential decision points, assessing psychosocial risk and protective factors, including patient and family values, and then making, individualized next steps about are they ready to schedule that team meeting? Do they need to see psychology beforehand? What could be the most, the sort of shared decision with moving forward? At our team visit, we always do the level setting that Jess introduced earlier, where we don't make any assumptions about who understands which terms, concepts, pathways. Oftentimes, youth come in with very different information than their parents, and we want to make sure everybody feels comfortable and on the same page. Our endocrinologist will cover the advantages, limitations, and potential side effects of any medical option a youth is considering. And then, of course, we also talk about all the non-medical interventions they're considering. We engage the youth and families around their expectations, and having this interdisciplinary team visit is really helpful because we're able to elicit and assess values from different perspectives and bring our different expertise into the conversation. And then we always give a very detailed after visit summary that has the next steps, which decisions have been made, which are still not made, and what would be the next steps to make those. And then if I meet with a youth before the team visit, I'll do the level setting just to again, make sure our family's on the same page. If they've already seen us as a team, sometimes I skip that. Sometimes I repeat it if it bears repeating. Oh yeah, I guess I already mentioned the Transgender Youth Fertility Attitudes Questionnaire, but it's one of my favorites. So I'll use an assessment battery to elicit more about the teen and the caregivers. And then one thing that I'm working on developing is a goals for gender affirmation and transition worksheet. I think if you click forward, I put an example on here. Yeah, so it has questions like, does your voice cause dysphoria? Do you want a deeper voice? How important is voice deepening to you? And then several options. And what I'm hoping to do with these worksheets that I'm developing is to normalize that not every aspect of an intervention is important to every person, and that people get to have individual feelings about what causes them distress and what they most want out of care so that we can individualize their treatment. Next. Okay, I think I talked about this, so I'm going to skip this one. So some reasons to go ahead with a decision is sometimes it's a natural transition point for somebody. It's a good time. If they're having a lot of distress, waiting can be harder. Their natural supports are readily available. They might anticipate insurance changes and we want to move before then. And then I think the next slide is some reasons to wait. You know, if somebody's pursuing a surgery, but they're not even done growing, you know, natural supports are not available or not helpful if their parents are not, or actually pose a safety risk to starting with an intervention. Unrealistic expectations for what they can do, or other life stressors going on, or desires for fertility preservation. Oh, just a couple things about the pandemic. We've noticed a huge increase in referrals, especially among trans feminine adolescents. And this has come with an increase in youth wanting to do medical interventions and social transitions simultaneously, which has not been historically the pathway. So it is a new sort of frontier a little bit. And then more non-binary youth than ever before for non-medical and medical interventions. Anytime a youth has a community mental health provider, we consider them an active part of the team. They can provide long-term mental health support and letters of support, because our clinic and many clinics like ours, we saw over 600 patients in 2020. So of course I can't be an individual therapist for 600 youth. Next slide. So I'll just briefly talk about letters of support because I know there was a pre-workshop question, but if you'll go to the next slide, Kara. So if a youth who's not in puberty yet wants a letter of support, we usually say no need. As has been mentioned several times, many young people don't go on to identify that way in adolescence, and that's okay. So there's no reason to pursue any medical treatment before puberty. Next. If somebody wants a letter for puberty blockers, that is very time sensitive because it can prevent irreversible changes to a person's body. It can prevent the need for future surgeries, and often insurance takes a long time because these medicines are expensive. So somebody may not have all their goals identified for their long-term gender affirming care, but if they're having enough distress from the changes from puberty, writing a letter for puberty blockers can be extremely helpful. Next. And then when you're thinking about hormones, I won't go over this too much because Dr. Edwards-Leeper already covered it, but that's when you want to start making sure somebody's goals really align with the medication, because also some changes are reversible, others are permanent, and you want to make sure that you're assessing a little further. Next. The only letters that we really write for surgery in adolescents are the masculinizing top surgery and the feminizing bottom surgeries. Those tend to be external organs that removing them can make someone's life a lot easier transitioning into adulthood. The other surgeries tend to not happen until adulthood, but it can be beneficial when you're an adolescent and emerging adult to still be at home where you have caregivers to provide support during recovery. So if you're someone who's asked to write a letter for surgery, there might be a good reason to do that. You can skip this because Dr. Edwards-Leeper covered that. And we just wanted to give you a little bit of a takeaway of why we do what we do and the positive comments that we get. So somebody said, I had no hope that my dad could change. The time and energy spent to support him so he could support me. I have no words. I've never smiled more. What you did was more than just an assessment for a letter. I didn't get a call back. I was told we don't do that here, or I was stuck for a kid in rural Oregon. You made the difference. You helped me realize I couldn't do this alone. And then you'll get these slides so you can read the rest because I think I'm out of time now. Oh, if anyone, I think we have a couple minutes, like 4 minutes for questions before our break.
All
right?
That sounds good. We have several questions. Let's, I think we can probably start one of them. To what extent, if at all, would a diagnosis of autism spectrum disorder influence how we should work with and support a teen who is transgender non-conforming? Does an ASD diagnosis complicate the way gender affirmative care is provided?
That's a fantastic question. I would say one of the primary ways it affects what I do is it changes how I do assessment a little bit. So people who have autism spectrum disorders tend to, for example, sometimes have harder time with written and spoken communication. So we might need to use more visual assessment tools to help them identify their goals. Even if somebody is not seeking, so that's, if they're seeking medical treatment, we want to clarify their goals, and that might be a little more complex than someone without a diagnosis. But even with non-medical stuff, sometimes helping them to be able to communicate to their family members, their providers, that can all be a little more difficult with somebody with any communication disorder. So I would say that's the primary way that it affects our care. Is making sure that we're helping somebody communicate their needs in a way that is appropriate for them.
Thank you. The next question, how do you determine whether or not a teen should see the psychologist or do more clinical work versus if it's time to keep moving onwards? Is it just about the depth of their insight and knowledge? Are you looking for certain things?
Yeah, great question. So Jess is very great at this on intake of identifying who might benefit from seeing me in addition to the team. And primarily I'll start with people who don't end up seeing me. Those are people who have therapists in their life who are knowledgeable in this area, that we know and we can communicate with, and they can be the team member so that I don't have to. So that's an easy, no need to see me. Reasons people might see me is if they don't have that and they will need one of those letters of support and they can't access a mental health provider who can write one. They might have complex diagnostic clarification that needs to happen that we want to make sure our team is doing internally. If we don't know if their therapist has experience in this area or if they don't have a therapist at all. And then a lot of reasons a team might see me is because they and their family have a lot of conflict around what it means to support their gender and to move forward with treatments. And sometimes it takes a lot of family work before people can come to that shared decision making. So I'd say those are the primary reasons people would see the psychologist in addition, like outside of the team. And then I determine during my assessment whether a teen has enough resources or we've done enough clarification at that point, or if we need to sort of follow up and have multiple experiences. So that's sort of on the psychologist to determine the recommendation for how much more is needed.
Thank you. Okay, I think probably our last question before the break. Do you have any spiritual consultants to address distress related to religious beliefs?
You know, we don't have somebody currently on our team. We've talked about this before, and I know there are some teams looking into this. We do have this resource available for anybody recovering from surgery, because we have the sort of inpatient chaplain service that we obviously offer to our patients as well. But we don't currently have someone on our team. But it is something that's on our mind. We've consulted with ethicists before and other perspectives. So we're always trying to see if there are more perspectives that can join our team. I don't know if anyone else has something to add.
I'll jump in. Just to add to the piece around chaplains, OHSU actually just hired its first pediatric focused chaplain, and we were able to be involved in that interview process. I don't think she starts till January, but that will be a resource for us. And then Mama Dragons, which is one of the groups that I forgot to list off, but I sent to Carmen in an email. They were formed by largely moms of trans kids who were raised in the LDS church, but have now expanded to support parents of any gender diverse youth who are kind of experiencing life at the intersections of faith, spirituality, and helping their child navigate gender identity exploration and transition. So we have that connection as well.
Great. Thank you so much. Now it's time for a 10-minute break. So we'll be back at 10 a.m. All right. Thank you.
Okay, I think we're going to go ahead and get started again. Am I still screen sharing? Is everyone able to see my screen?
Yeah, you are
Yes.
your screen. I sent Jess handout to review, so I can.
Okay. Perfect.
All right. So.
And I did turn off those WebEx notifications. I apologize for that earlier.
Thank you so much. All right, we can start whenever you're ready.
Okay, thank you. So in this section, I'm going to be talking about some of the different medical and non-medical interventions that we talk about in clinic. I understand that there's a large number of behavioral health professionals in our audience, and so I really tried to gear this towards information that would be helpful for behavioral health specialists to be knowledgeable about to be able to communicate with their clients, and also for primary care providers. And I think that if you walk away with anything today, I think one of the most important messages that we would like to communicate is that the care that we provide needs to be, should be, is, and needs to be individualized. We see every patient as a unique individual, and their family as unique, and we really want to understand and help that individual family unit find the options that best work for them at any given point in time. And it is a longitudinal process, and we have the benefit in the medical world or within our clinic to be able to follow our patients for a really long period of time. And so what I always talk about at the team visits when I'm first meeting patients is the fact that we often use this word transition, but we see that term a little bit problematic because that almost implies that there's a starting point and an ending point, and then there's this linear process from start to end with the different expected stops along the way. And as you've heard this morning from the other speakers, is that we really see it more of a journey with a lot of different paths that someone may choose to take. And we recognize that someone may go down one path and then want to change direction or change course. And we want to make space for that, for them to be able to express that if they do come in saying that, you know, even if they've started a medical intervention, it's not feeling right to them, we can talk about what it would look like to change course. So with that, we focus a lot on non-medical interventions in addition to medical interventions because there's lots of different ways that someone may be able to affirm their gender expression. And throughout this section of the talk, you'll see these acronyms AFAB, which stands for assigned female at birth, which presumes that the individual was born with ovaries and has an ovary-driven puberty, and then assigned male at birth, or AMAB, someone who presumes to have testicles and has or will undergo a testosterone-driven or testicle-driven puberty. So I'll talk in more detail about some of these non-medical interventions. We then have hormonal, which can include pubertal suppression, may mean non-hormone, like testosterone or estradiol interventions that don't actually physically change the body, or it may include hormones that are listed there, and may include surgeries. And what I often will tell individuals is that some patients will, after meeting with us and get the information, or even before meeting with us, will decide that they're really, that medical and surgical interventions don't really line up with who they are. Sometimes they just want hormones and no surgeries, sometimes surgery, no hormones. So we want them to best understand what all of the different interventions are so that they can select with their team and their family what are the ones that best fit with who they are. And underlying all of this, it's really important for us to avoid gendered language. And so really trying to use affirming language in terms of referring to an individual's body parts. We put a lot of information, or a lot of work into discussing fertility implications every step of the way. And then considering implications on sexuality, sexual function, sexual satisfaction, and how any of these interventions can have an impact on that. So diving a little bit more into the non-medical interventions, lots of youth who had chest development from an estrogen-driven puberty may want to bind their chest. And the reasons why they might want to bind their chest are varied. They may feel more comfortable in their clothes. Many youth say that they want to pass or be recognized as their gender identity in society. There may be safety concerns, such as using certain bathrooms. And then there's a huge emotional improvement from dysphoria relief with binding. So while binding can be really beneficial, it's important that they do it safely, because if they aren't binding safely, that can lead to short and long-term health problems like breathing restriction, skin problems, problems with the chest wall development. So the things that we have handouts that we give to families that are actually available on our website, and the guidance that we provide is to really avoid using ACE bandages or duct tape because they're too restrictive. And there are many different types of binders. We give families suggestions for lots of different websites for looking for the appropriate types of binders. There's also something called trans tape, which is depicted in the lower photo here, that doesn't go all the way, or doesn't have to go all the way around the chest, and may be beneficial for certain body types. We want to make sure that the binder is not too small, and there are some places that can do fittings. We provide guidance in our handouts about how to measure their body chest, how to do their chest measurements accurately so they get the right size. We recommend that they don't bind for more than 8 hours consecutively, and they take off their binder to sleep, or to consider a larger size if it causes pain or discomfort. We also recommend that they consider a looser binder or something that's specifically developed for exercise, and then to clean it regularly, so there may be benefit to having more than one. Tucking is referring to, for those individuals who are born with penis and testicles, this refers to moving the penis and scrotum posteriorly in the perineal region. Some youth want to use tucking and some don't, and so we just want to make sure that if they do, that they're doing it in a safe way. Same kinds of reasons why youth may choose to tuck as why youth may choose to bind their chest. Sometimes the testicles are moved into the inguinal canal, and we have some guidance for young people on our handouts about how to do this safely. And then there are some special underwear and undergarments that are preferred over even medical tape. If they are going to use tape, we always say not to use duct tape and to use medical grade tape. And we want to make sure that they're not tucking for prolonged periods of time or in ways that would delay urination, as that can lead to some health problems. Some youth who are assigned female at birth who have undergone menarche or are having regular menses, which I usually refer to as cycles, may want their cycles suppressed. Some individuals experience really significant dysphoria around their cycles, some don't. When I talk about different interventions for inducing amenorrhea or suppressing cycles, I usually talk about progesterone-only interventions. Many of our youth aren't interested in more estrogen as what is included in traditional combined birth control pills or oral contraceptives, and so that's why we use the progesterone only. However, sometimes the progesterone only is not successful, and we may need to go to estrogen-containing OCPs. The GnRH agonists, which I'll talk about in a moment, are for pubertal suppression. We generally don't start if somebody has already achieved menarche for some of the health concerns that I'll discuss in a couple of moments. When I'm talking about progesterone interventions, progesterone-only interventions, I am talking about oral progesterone. I usually prescribe norethindrone acetate. There's the Depo-Provera injections. There's Nexplanon implant that is effective for 3 to 5 years, and then a hormone-containing intrauterine device, or IUD, that is effective for 5 to 7 years. That does require a procedure, and we do have doctors on our team that can place them under sedation if needed. And then testosterone can also induce amenorrhea, but we don't want youth to feel like testosterone is their only option if that is that testosterone is the only option if that is their only goal, is to suppress cycles. And then for youth with testicles who want to suppress testosterone effects, if we're not using pubertal suppression, we may think about spironolactone or bicalutamide, which are both testosterone receptor antagonists. So basically means that it blocks the binding of the hormone to the receptor. So it's not 100%. So there will still be some effects of androgens, but it does prevent some of the androgen effects. And my patients who are on spironolactone or bicalutamide are those who have either achieved most of their testosterone during puberty and pubertal suppression wouldn't really be indicated, or if they can't get insurance coverage or can't afford the copays or out-of-pocket costs of pubertal suppression. And what the effects that they typically will experience are a reduction in hair growth and a reduction in spontaneous erections. And then for bicalutamide, there's a side effect of breast development. This is used a lot less often, just because in the adult literature, there's a risk of liver inflammation or liver failure. So in order to understand when different interventions may be indicated, it's important to know what is typical in terms of pubertal timing, and it's different for youth with ovaries and those with testicles. For youth with ovaries, typically puberty starts on an average of 10 to 10 and a half years, but can be anywhere between 7 and 13. For 85% of the youth with ovaries, chest development or thelarchy is the first sign, followed by pubic hair, then the growth spurt on average at 11 and a half years, and then menarche or cycles. A lot of young people are concerned if they have their first cycle that they're not going to grow taller. And it's important to know that even after their first cycle, most youth continue to grow for another year or two, and they usually achieve about 2 to 3 inches. And then usually by age 15 is when growth is complete. For youth with testicles, the average onset is 11 to 11 and a half, or anywhere between 9 and 14 years. Most youth start puberty. The first sign of puberty is testicular enlargement, even before the appearance of pubic hair. So that's why, as a primary care provider, it's important to consider this as part of the well-child checks. Obviously, a genital exam or even chest exam can be, or any kind of physical exam can be distressing to a young person with gender dysphoria. So it's important to take that into consideration and obviously get consent for any portion of your exam. And I really spent a lot of time discussing why that part of the exam is important and what purpose it can serve, so that they can make the decision about whether they want to allow that or not. So then followed by pubic hair, genital growth spurts around at 12 and a half, and then testosterone-driven puberty extends well into the adolescent years and even young adulthood. And so this is important to know because even for those youth who were born with testicles who are in their mid-adolescence or late adolescence, they may not have had all of these later changes happen yet, and so they may still benefit from pubertal suppression to block some of these things like development of the Adam's apple, facial body hair development, and then changes in the facial bone structure. Puberty is a really gradual process for testosterone, as I mentioned, over many years, and usually growth is complete around age 17. And another important part of pubertal development is the age of when they reach fertility maturation. And so the median age of spermarchy, which is the appearance of fully developed sperm, is around 13 to 14 years, or midway through puberty, 10 or 3. And then sperm density increases over several years. So this is an important implication for those youth who are considering medical interventions, but have not yet achieved spermarchy in terms of fertility preservation. So there's a couple different ways that we can determine the onset of puberty. Physical exam is one of those I kind of already talked about, and we stage puberty in 5 stages. The first stage is the prepubertal, so we call it Tanner stage 1. There's no signs of puberty. Tanner stage 2 is when, in someone with ovaries, it's when there's breast buds that develop, and in youth with testicles, the testicles begin to enlarge. And then it continues on through stage 5, which is when puberty is complete. We use this tool called an orchidometer, which helps us to size the testicles. And we know that around 4 mLs of volume is when central puberty has started. So that's kind of the first sign of puberty. We can also measure hormones, and we consider this in a couple of different situations. One is if the young person is really resistant to the physical exam because of distress that it will cause them, or if the physical exam is inconclusive, then we can measure hormone levels. I generally say that the physical exam is more sensitive than the hormone levels, but sometimes we have to do both. And so we measure gonadotropins, LH, FSH, and sex steroid hormones. It's best to measure them in the morning. So for those who are ordering these labs, that's when they're at their highest early in puberty. And we prefer a special lab called Esoteric, just because they can measure hormone levels with really low amounts to really detect if puberty is starting. And so we're really lucky that we have this category of medications that we call pubertal suppression or gonadotropin releasing hormone analogs. they actually are a synthetic form of a hormone that's naturally produced from the hypothalamus in the brain when puberty turns on. And what the natural GnRH does is it's secreted in pulses. It's depicted here in blue. What our medications do is it gives it at a steady amount. And so by turning off these pulses, that turns off the signal down to the pituitary gland, where hormones are then being produced that tell the testicles and ovaries to make testosterone or estrogen. And so it really turns off that production here so that there is no more testosterone or estrogen coming out of the ovaries or testicles. And there's a lot of benefits to pubertal suppression. It can allow youth to continue to, be themselves and live free of the fear of any further development of secondary sex characteristics that may not be in alignment with their gender identity. This can also facilitate their social transition. As my colleagues were mentioning, it can prevent irreversible changes. So if chest development does not align with someone's gender identity, and we're able to prevent that, then they may not have to undergo removal of the chest tissue or top surgery in the future. And they don't cause any permanent changes to the body, so they can be stopped at any time. But there are a couple of implications that I'll talk about in terms of thinking, future steps. So if they're using pubertal suppression and then decide to start hormones or go on hormones later on in life, then there can be some long-term changes. This is a picture of Nicole and Jonas Maines. Nicole has a book, and she identifies as a trans girl, and you can see that she was able to access pubertal suppression early in puberty. This is her identical twin. They were both assigned male at birth and were born with testicles, and so you can see that as her twin brother is undergoing changes related to testosterone-driven puberty, that she is not. So pubertal suppression is most beneficial for those who initiate it early in puberty. Obviously, the more that we can prevent, often the better. But there may be some individuals that may benefit with pubertal suppression later in puberty. So like I said earlier, if individuals have started puberty or midway through puberty but haven't completed it, then there may be benefits to starting. If we are using post-pubertal, so if someone was born with testicles and then they haven't completed puberty, that may be beneficial to them. And then if someone was born with ovaries and identifies as trans male or masculine, that may be an option for achieving amenorrhea if other options don't work. But again, we try to avoid that due to some potential side effects. There's a couple of different options. The most common are injectable forms. Leuprolide and triptorelin are the generic names. They're intramuscular injections that are given, depending on the brand, they're given either at 1, 3, or 6 months. And there are pediatric and adult formulations, which is important to note just because the costs of those are different, but they work the same. There's also an implant form with a medication called Histrelin. And this is, it's a simple procedure. We have a doctor on our team who places them in the office. Sedation can be used, but we don't usually need it just because it is a relatively quick procedure, and just with sometimes oral anxiolytics and distraction techniques, we can be successable. The suppression effects last between 1 and 2 years, sometimes, and perhaps even longer, is something that we're studying right now. And so, but when we're counseling folks about how long to leave them in, we let them know that removal may be more difficult if they're left in longer than 2 years. So the limitations of pubertal suppression is that they don't reverse any pubertal changes that have already happened. And then if they're started midway through puberty, this could lead to temporary fatigue, sometimes hot flashes, mood changes, or lower mood. And that's related to the fact that sex steroid hormones are going from mid pubertal levels down to 0, and that happens pretty quickly. And so it's important to just to know that that is a possibility. It also temporarily suppresses the growth spurt, and that's important to note too, because if it started later in puberty, they may not be able to fully achieve that growth spurt back. So looking at where they are in the growth chart with their pubertal stage is important. There's also temporary suppression of bone mineral density because puberty hormones are an important building block of bones. And so if we're taking that away, temporarily, then it's important that we keep bones healthy in other ways, and we usually say sufficient levels of calcium, vitamin D, and regular weight-bearing exercise are important. And that's also the reason why we can't use pubertal suppression indefinitely, because bones it will eventually need hormones. So we usually say research has shown that between 2 and 3 years is probably safe for bones for a duration of pubertal suppression prior to initiating hormones. And then the other thing that's really important to know is that they don't cause permanent changes to the gonads, and we'll talk about fertility more in a later section, but they do halt the development of the gonads at that point in time. And so if somebody if someone is not yet making eggs or sperm, then if we're starting pubertal suppression now, then they won't ever get to that point. And then there's questions about whether, what effects these can have on youth exploring sexuality, sexual function, sexual pleasure. And then, as someone mentioned earlier, these medications are extremely costly. I put upwards of $40,000 a year, but it can be even more than that. So insurance coverage is essential. In terms of hormones, the starting age is individualized. We often get this question of, what's the age that someone starts hormones? And again, we approach each person as an individual. We follow published guidelines in terms of criteria for starting hormones, and those are focused on the individual ability to make complex cognitive decisions, can understand the irreversibility or changes that can be reversed or not reversed after taking hormones, and that they have the capacity to give informed consent. And so the reasons why we might think about starting at any given point in time is knowing that as their peers are going through puberty, if they're being continuously suppressed, there can be feelings of social isolation and worsening anxiety or depression. Not for everyone, but for many. And then again, the implications on bone mineral density. But there are some that may that may not be appropriate at a younger age and may want to wait until they're older. And in our experience, it's typically those who are still considering fertility implications, or maybe uncertain about physical changes and really wanting to explore their gender expression more. Anytime we start, we have a really comprehensive discussion, and many times this happens over various visits, so it's not just a one-time discussion. These discussions also happen in meetings with my other colleagues and disciplines on my team with social work and psychology. We talk about expected changes in typical timeline, side effects, any impact on fertility that they may have, and then we assess for risk factors for complications. Primarily for those starting estrogen, we think about clotting disorders, tobacco use, and for those starting testosterone, history of early cardiovascular disease in the family or high cholesterol levels. And then we always try to mimic puberty as closely as we can. So we start at a low dose. We gradually increase over the course of 1 to 2 years, and during that time, we're monitoring growth closely, trying to minimize the risk of side effects, and then monitoring mental health as well. This is on handouts that we give out to our patients, and is taken directly from the Endocrine Society clinical practice guidelines. And so I won't go into a lot of details here, but the things that I try to emphasize to youth is to really help them understand that the changes happen very gradually. And for most of our patients, it's a lot slower than what they're anticipating or hoping for or wanting, even after having this counseling and various reminders of the changes are going to happen gradually. And there can be feelings of frustration around the changes happening too slowly or more slowly than what they're hoping for. And so for that reason, we always encourage ongoing work or involvement with a mental health professional in case those feelings do come up. And then I try to help them understand the different time points that some of these changes happen. Some people ask about progesterone added to an individual assigned male at birth who is on estrogen. There's no published research to support the use to demonstrate benefits or disadvantages, and but I just counsel patients on the possible. Some people report improved breast development, mood, or sexual desire. There's a possibility that it could be worsening depression or suicidality with progesterones, and so I just want to make sure that they understand, have realistic expectations, and understand the implications. And so the last piece is just the role of the primary care provider. When to refer, there is no set rule about what's the right time. If it's not a bad idea to refer early, but it's important to understand the why. And so the important messaging, and we think that's important to communicate to families, is that our team provides more than medications. The pacing is slow and individualized. Many patients don't go on medications, but continue to follow along with our team. We try to move the family unit forward together. We rely on current best practices and guidelines. We involve mental health support. Our wait times, unfortunately, are longer than we'd like. It's something that we're working on, but typically is about a month to two to have the intake call, and then about 6 months, sometimes a bit longer, for the medical visit. And then again, doing nothing is not a neutral option. It's important that they understand what the wait times are. PCPs can play a really important role in thinking about progesterone-only cycle suppression or spironolactone for those who are assigned male at birth going through testosterone puberty, because those have really low risk of side effects and can temporize some of those symptoms that are distressing. It's important to note in the referral if the parents are aware or supportive, if there's any DHS involvement, and then for peripubertal youth to perform and document a pubertal exam when possible. So with that, I think I just have a couple minutes for questions.
Thank you. We do have a couple of questions. First question, can we get the websites and handouts for binders?
Absolutely. We will make sure to pass that along.
Thanks. Does Hysterine implant require a special training like Nexplanon? And can FM place these, or does the company require endocrine to do it?
The company does not require endocrine to do it. In fact, the physician who places them on our team is adolescent medicine. And it does require a special training from the company. So it's a very, very similar to Nexplanon placement, but just a couple of different specifics around the device, the insertion device. And so our adolescent medicine doc got the special training from the company, and then she's actually performed workshops for primary care providers to be able to learn how to do these in the office. And if anyone is interested in that information, I'd be happy to connect you with her.
Great. Our next question, can spironolactone be helpful with reducing unwanted facial hair after puberty?
So what I counsel you individuals about is that spironolactone, it won't prevent hair follicles from developing, because it doesn't 100% block testosterone's effects. But what most of my patients on spironolactone will experience is that they experience less hair growth, and that if they're shaving it, they have to shave, that they shave less often.
Thank you. With that, we have covered our questions for this section.
Okay, thank you.
Thanks.
So we are going to head into our next topic, hot topics, when we'll talk about a variety of things that we think are important to know. And again, just as Dr. Edwards-Leeper was mentioning earlier, it's really tricky to try and give a really, a short overview on all of these things, because there's so much depth that we could go into, but we really want to try and give you kind of the surface level information that will hopefully be the most useful. So I'm going to dive in and just cover the fertility and surgical considerations. So as I mentioned just a few moments ago, in terms of the pubertal suppression or the GnRH agonists, they don't cause any permanent changes to fertility. And this is based on research done in children given these medications with precocious puberty, these medications for precocious puberty. So there's not a lot of research still in youth who start these medications early in puberty for gender dysphoria. So that's an area that's still being investigated. If someone is considering fertility preservation, they have to have completed at least 10 or 3. So if y'all remember the Tanner staging, it's about midway through puberty. And along with that comes physical changes. So if it's somebody who was born with testicles, that's usually voice deepening, sometimes hair growth, height increase. And so it's really balancing the physical changes with the desire for preserving fertility. So that's an important thing to know. In terms of hormones, research has shown that estrogen can cause permanent changes to the testicle's ability to make sperm. Most individuals who have been on estrogen, especially for a longer period of time, do end up having a reduction in testosterone production and sperm production, even if they discontinue estrogen. And so that's an important piece to know. We know that testosterone can alter the ovaries, but what we're finding in the literature, and especially in experiences with our fertility clinic and fertility specialists, is that most or many, if not most, patients who were assigned female at birth and have ovaries and a uterus, even if they've been on testosterone for many years, they almost always resume cycles after stopping. And then they can either go on to carry a pregnancy or have their eggs used for someone else to carry a pregnancy. And then I always, at every visit that someone comes back, that I see someone who's on testosterone but has ovaries and a uterus, I remind them that testosterone is not an effective form of contraception. And so they could still be at risk of pregnancy even if they're not having cycles. And then surgical interventions can have implications as well. Orchiectomy or removal of the testicles. There's been some early studies to show that if individuals had undergone some pubertal development, so this is done in adults, that there may still be some sperm that can be retrieved at the time of surgery, but especially in the youth who have not yet completed puberty, then again, we don't have any information about that. And once testicles are removed, that's obviously there's not going to be any more potential for fertility. So we still a lot more research that needs to be done in terms of the peripubertal youth started on pubertal suppression. And I would say that just speaking for the rest of our team, this is probably one of the most, if not one of the most or the most challenging topics to cover. And we think about a lot of ethical considerations, and this is something we spend a lot of time talking about with families and youth, and often over many appointments. Because they're young people who are considering interventions that can and will have long-term reproductive health repercussions. It's not developmentally normal for them to be thinking about this at this age, and they may not really, their reproductive goals may not be well defined. They may or may not. And many of them are opting to prioritize gender affirming treatments over fertility. And the way that we kind of explain this is that there is a real, in many cases, a real present distress about body changes that they're going through from their endogenous puberty that they were born with that are causing them significant distress that aren't in alignment with their gender identity. And they're weighing that against the possibility of distress in the future related to the ability to have biological children or loss of the ability to have biological children. And so we need to consider both of those things and when we're having conversations and discussions. There's also other things as, obviously the parents' opinions and a parents' perceptions. And many of them do want you to pursue fertility preservation and or allow puberty to continue to develop so that their young people can avoid feelings of regret. And it's interesting, we have these discussions with all of our patients, and there's such differences across patients and family units, and a lot of it is based on the family unit's values and what it looks like to build a family. In these conversations, we definitely still need to consider the autonomy of the youth to make reproductive health decisions, obviously considering the developmental stage of the young person, and also recognizing the right of gender diverse youth to be parents in ways that may be different than typical normative family structures. And so we always acknowledge that there's many different ways of building families, and then emphasizing that these discussions involve the parents and caregivers. I'm going to just briefly talk about surgical interventions. And again, the care that we provide is very individualized. Dr. Moyer and Jess do a lot of this work way more than I do with patients, but really looking at what does the patient support system look like, what are their expectations and knowledge of surgery. And we're doing a lot of work around making sure that youth are asking the right questions and are as best prepared as they can be for surgical consultations before they go in to meet with a surgeon. We think about the appropriate timing, now versus waiting, and what that would look like. We think about who are the decision makers and need to be involved in making decisions. And then we think about future plans. And so especially for our late teens who are finishing high school and are planning college, there are benefits to having them be able to undergo surgery while they're still living at home with in the care of their parents who can help them with their healing and recovery process. So for those patients assigned female at birth, most of them are in our clinic are in adolescence or pursuing chest masculinization surgery, which is often referred to as top surgery. As Dr. Moyer mentioned, we want to make sure that linear growth is complete because that can affect scar healing. Most common surgery is a double incision with free nipple grafts, but the surgeons will talk with the patients about lots of different options. The less invasive procedures, I mean, many of our patients say that they want keyhole because there's not as much scarring, but we have to help them understand that most patients are not candidates for that. It's really those with small chests because and there is a higher risk for need for revision surgery in the future. And then wait times can be long and they vary. And so it's important to be knowledgeable about what the typical wait times are. Right now, I would say for consultation, and this is across multiple surgery or surgeons across the city, it's between, 6 to 18 months for a consultation. And then for genital surgery, some of late teens, young adults are thinking about hysterectomy and oophorectomy. When we're talking with them, we always encourage them to maintain their ovaries, at least one of them, because it'll be a source for hormones in the future for bone protection. And then some are thinking about or asking questions about genital surgery, but most are not undergoing the surgery in adolescence. But these are just some of the points to be aware of. And then for our patients who were assigned male at birth, they may pursue chest surgery or breast augmentation. Again, most of our teens aren't pursuing this because they're waiting for estrogen to have the effect on their chest. But some are considering genital surgery, and this can involve several different things. It may just mean an orchiectomy or removal of the testicles and or the penis. And if that is the case, again, fertility, a lot of discussions around fertility implications, and need to ensure that they do have access to lifelong hormones to keep their bones healthy. So that's a really important piece. And then they may be pursuing either a vulvoplasty or vaginoplasty, and that they don't have to happen together. So vulvoplasty is this creation of the external vulva. Vaginoplasty includes creation of the canal. And the things that we're really thinking about now is that for those youth who had puberty suppressed early in life, there may be implications in terms of the type of surgery that can be performed. Some of the classic surgical techniques involve use of the penis and scrotal tissue for creation of the canal. And if youth were suppressed early on in puberty, they don't have as much tissue. But there are some newer techniques, a robotic-assisted peritoneal flap vaginoplasty that one of our surgeons here at OHSU does that may have promising results because it doesn't rely so much on the genital skin. However, a lot of research is still needed in terms of outcomes. And then the nice thing about the robotic surgery too is that it does allow for the possibility of creation of a vulva first and then creation of a canal later on, because creation of a canal will require lifelong dilations. And so that's an important piece to make sure that youth are ready for. We work really closely with all of our surgical colleagues. The nice thing about OHSU is that we are within the same system, so it really allows for good care integration across disciplines and clinical departments. We work closely with primary care and all the surgical subspecialties. We have monthly multidisciplinary meetings where we are discussing care coordination for surgical patients, and we always present minors at those meetings, any minors that are pursuing surgery, to be sure that they're best prepared for surgery. And then social work is always involved in surgical prep and post-op. And I will turn this over to Jess.
Okay, is my audio good? Great. So I wanted to talk a little bit about how we think about and approach conversations about sexual health and sexuality. Again, thinking about what Dr. Connelly mentioned regarding sort of what is typical on a developmental trajectory for folks to think about it at different time periods. And in some cases, when we're talking about different medical interventions that have implications on sexual function, it often means that we're having to have these conversations at periods of time in someone's life when their peers are not thinking about it, when the adults in their lives are saying, think about anything but this, and they haven't had sort of experiences to draw on to say, yes, you know, I know what pleasure feels like, I know how my body reacts to touch, things like that, and being able to project that into the future and say, yes, I want this, no, I don't, and how that relates to different medical options that are available. And so when we're talking about informed consent, obviously we have to cover these topics, but it's complicated to think about how we assess true understanding of function. And in this case, you know, we're talking about potentially 11, 12, 13, 14-year-olds, or in some cases in states where the age of consent is 18, their parents are consenting for them. And in the realm of sexual health and sexuality, that's kind of a weird topic for a parent to consent on behalf of their child for. It kind of crosses the line for both function and sensation, and getting people to think about how they might want to experience their body in the future when they are uncomfortable in their body right now, can also be a very difficult exercise. And this is, alongside the fertility conversation, another one of the challenging conversations that we have in our group, trying to problem solve the best way to go about this. And we don't have any magical golden answers other than to really try to focus on delivering the information about what we actually know, and then trying to translate it to a developmentally appropriate level for each individual child or teen that is in front of us. And in doing so, sometimes just naming the discomfort or the awkwardness for the young person is important, and recognizing that they generally don't want to talk about sex at any particular age, and they certainly don't want to do so with adults that they don't know super well or with their parent in the room. And so how can we set up an environment where they feel like they can talk openly, ask questions openly, and diminish some of that awkwardness a bit. There are some resources out there. The Human Rights Campaign has the Safer Sex for Trans Bodies PDF guide. It's largely geared towards, I would say, later adolescents and adults, but has some good information in there. And then there are some books like What Makes a Baby and the Every Body book that we draw on for help as well. And then we have to think about who ultimately makes the decision. Again, there are the legal implications and the legal precedents of who gets to sort of officially sign on the dotted line, but we're really talking about body autonomy and reproductive rights for young children. And we believe that you know, gender diverse youth have just as much right to determine what their future sexual life and parenting life looks like in the future. And so how do we ensure that the patient voice is involved in the discussion and that we understand what their values are, even if they're not fully developed yet? And again, these are just questions that we think through. Next slide, please. And then when it comes to folks who are sexually active or who are thinking about being sexually active, we tried to talk about safer sex and the idea that there are kind of two major areas that we need to pay attention to. One is navigating consent, and then the other is prevention of harm or harm reduction. And when we're talking about consent issues, it's important to recognize that there can be negative self-worth that can play into risky behaviors and put someone's physical safety at risk. And so making sure that folks know the importance of consent and the ability to say no at any time, and even rehearsing that in the clinic room. And then another topic that comes up a lot for our young people is how, when, or if to disclose their gender identity to their partners, especially if they socially transition early, have medical intervention early, and complete all of their medical transition goals before launching into adulthood. This can be a very complicated world to navigate. And then in terms of prevention and harm reduction, when we're counseling about safer sex, we want to focus on the body parts that folks are using and the practices that they're engaging in, and not their gender identity or their sexual orientation, and making assumptions based upon that. And then we also have to recognize that there may be a lower rate of usage for our typical tools or practices around safer sex, because there's an aversion due to the fact that many of them have gendered meetings or advertisements or whatever. And so finding ways to translate that and to encourage people to make informed decisions and find ways to reduce harm if or risk if they are not going to be using the tools available. And I will turn this over to Dr. Moyer and Dr. Edwards-Leeper.
Yes, I believe Dr. Edwards-Leeper is next. If we can give her the screen share ability.
Working on it. There we go.
Okay. All right, I have to do my little move adjustment here. Hold on, everybody. Okay. All right, so I'm going to talk a bit about family, just briefly. We've been talking about this throughout because obviously when we're working with youth, family is really important. And I thought I'd start just by quickly just highlighting a few of the challenges that trans youth and families encounter. And I thought this would be helpful just because it sort of gives you an idea of all the different things, or at least a handful of the things that we work on in therapy, or when families go to a clinic like OHSU to help address with them. Okay, so first, just the question of when and if to transition socially and physically. There are a lot of different issues related to school, how to come out at school, if to come out at school, what bathroom to use, what locker room to use. There can be a lot of stress around public bathrooms and which of those bathrooms to use. That can be a huge source of distress for individuals. Medical appointments can be really difficult if going to a clinic that doesn't specialize in gender, so just like primary care doctor or pediatrician, if they're not knowledgeable about how to best approach the care in a sensitive way. Reactions of family, so extended family, immediate family, friends, neighbors, religious community, all of that is something that lots of families struggle with. There's an impact on parents. So like most parents, to some degree at least, experience a feeling of loss and having to come to understand their child differently than how they had thought of their child. And that's very real for a lot of parents. And many of them get through it if they have support, but initially it can feel very hard. There's also an impact on siblings sometimes. Sometimes siblings can be the biggest source of support, but other times siblings can become the target of bullying at school because they have a trans sibling. So we need to look out for them. As Jess just talked about, romantic relationships can be difficult to navigate. Just the stigma of not fitting into the gender dichotomy and all the bullying and teasing that can go along with that, as well as more extreme rejection by families, which can lead to horrible outcomes like homelessness, substance use, and sex work. So I thought I'd just share a few things, suggestions in working with parents. And this applies to little kids, but also adolescents. So part of it is really helping parents with identity acceptance of their child. So encouraging their parents to focus on loving their child for who they are and the qualities they possess, and discourage them from pressuring or shaming their child into changing who they feel they are, which is what I talked about earlier with kind of that conversion therapy or any kind of pressuring their child. Another big component is education and support. So encouraging parents to really re-examine their own beliefs about gender roles and embrace a less dichotomous conceptualization of gender can be really, really helpful. I really enjoy working with parents individually to explore what their childhood was like and what kind of expectations were placed on them and what did they grow up thinking had to be true for boys and girls, and really try to help them expand that. Also educating parents about the current trends regarding long-term outcomes of children with gender dysphoria. And obviously to be involved in this work, you really have to stay on top of the research and what's happening, because there's more and more research being done all the time. Really emphasizing the importance that parents thoughtfully take their child's lead and allow their child the freedom to change their mind at any point. I've said that before, but I really can't emphasize that enough, in part because sometimes parents really struggle with the ambiguity. They really just want to know, and they're thinking from a binary lens, and they really want to know, is my child a boy or a girl? I don't really care which, but I just need to know. And I've even had some parents, when I've commented about the importance of keeping the door open, get kind of frustrated with me and say, we've already told everybody that that our child is now our son, and you're telling me that we might have to tell everyone something different in the future. So it can, for some parents, that can be really a hard idea to contemplate, but it is really important, obviously, that they are open to that. And just being aware of the impact of the transition on the parents and other family members, and provide support and other mental health referrals if necessary for the parents. Some things that come to my mind that happen sometimes are a religious community that's really important to the family, not being supportive of the parents' decision to allow their child to socially transition, for example, and there can be a big rupture in that support network, or extended family who doesn't agree with the parents' approach. It can cause a lot of distress for the parents. In terms of action and advocacy that parents can do, I always recommend that parents provide both stereotypically masculine and feminine activities for their child. And this is not just for their gender diverse child, but for all of their children. That's a really important message. Creating a safe environment where the kid can engage in the activities that they like to do. Talking about safety issues is important. So depending on the community where the family lives, that they may have to take a slightly different approach if it feels like it might be unsafe, for example, to go out in the neighborhood wearing different clothing or the clothing that the kid wants to wear. And that can be really difficult. And there are certainly situations where families move, to new neighborhoods or new cities altogether, new parts of the country, if they feel like it'd be safer for their child, but that's not realistic for every family. So we have to be realistic about what we can recommend for an individual family. Helping the families decide about transitioning, I already mentioned that, and just navigating how others may respond. Again, in the Portland area, this is not a big deal. I haven't really seen this as a major problem for families going through this, but in other parts of the state or other parts of the country, it can be a much more stressful situation. Helping parents determine who to disclose this information to, like at the school and elsewhere. Not everybody needs to know. In some situations, the child and the parents prefer to keep it kind of on the down low, and they understandably feel like it's nobody else's business. And just helping them advocate for their child in different settings. Some common challenges with parents include parents who are separated or divorced, particularly if they have really different opinions about what to do. I have one case right now with a 14-year-old whose parents are divorced and have been for a long time, and there's so much tension in the relationship between the parents that I do feel like one parent is sort of using, like resisting the gender process and transition for the kid, largely because they want to just go against the other parent. And so I'm really trying to work with that parent, try to help them recognize that and think about what's best for their kid. So there can be a lot of work that can go into that sort of situation. Also, there are parents who are just not on board with their kid starting medical interventions, or even socially transitioning, or changing name, changing pronouns. It runs the gamut. Again, another case I'm working with, this 13-year-old assigned female at birth just wants to cut his hair. He has very long hair, and the parents will not allow the kid to get his hair cut. And so with that family, I'm just trying to target that right now, because that would actually really just decrease the distress for the kid. In other cases, it's more about medical interventions, of course, and concerns around that. And so again, just working individually with the family and the parents to try to figure out the best plan. Sometimes parents disagree with how to proceed with, they may disagree with each other, they may disagree with the teenager, particularly if it's medical stuff. So that can, cause conflict and require a lot of family work, as the OHSU group has been talking about. Parents can also be anxious themselves, and sometimes it's very understandable. I sometimes joke that I probably would be one of these parents that, if my kids' puberty was starting and they were trans, I would be wanting to get them on blockers right away, or get the assessment to make sure that was the right thing to do. But and so it can be difficult when there's a long wait list. One of the things that I do in my practice is I just kind of squeeze people in quickly if it's a puberty blocking situation where the kid's right at the cusp of puberty and there's a time issue. I don't put them on my year out wait list. So it's a realistic freak out with that. But also, like I said, sometimes parents are anxious just because they're not comfortable with the gender fluidity. Sometimes parents are not comfortable with the idea that their child may be gender fluid or non-binary. And so that's important to work with them on. They can also be annoyed by the process, by the cost, the time that's involved, by the wait lists. And then more recently, this is actually what I spend a lot of my time doing these days, is consultations with parents around the country. These are for adolescent clients, most of whom are kids who do not have childhood gender dysphoria, or at least were not open about it. So it's kind of new to the parents. And most of 99% of these parents, I should mention, are very liberal, left-leaning parents. These are not conservative, or there's not like a religious component to these parents that contact me, almost always. But they a lot of times feel like their perspectives aren't welcome. And this is, oftentimes it's with the therapist that they connect their kid with, sometimes with the clinics that they go to. They tell me that they're often told that they're being unsupportive if they're confused, or they're questioning where their kid's gender dysphoria came from. Sometimes actually a lot of times it sounds like, from what they tell me, they're not included in the evaluation process or the therapy that the kid's in, and the medical decision-making process. So very different from what OHSU does. Not every clinic out there, unfortunately, takes such an interdisciplinary team approach and involves the parents. And so the parents are frustrated about that when that doesn't happen. And they also are sometimes told that if their recollection of their child's or their teenager's childhood is different than what the teenager reports, then that it's not valid. They also a lot of times feel that the teen's mental health concerns aren't being addressed adequately. They worry that their teen may be influenced by social media, as I think Jess mentioned that earlier. Parents are worried that kids may make irreversible decisions that they may later regret. And they have a hard time, that they tell me, finding providers who, what they often say, will just blindly kind of affirm and not really explore the gender with the kid. So finally, in my last minute here, it's really important, I think, to remember that the child or the teen is our client, and we absolutely need to advocate for them. But most youth live within a family system, and so we need to support the parents too. And the best way to support the kid is by helping the parents get on board and helping them with the struggles they're having. Using a developmentally informed process is really critical. We have to remember that families go through a transition too, which sometimes teenagers kind of like forget. Like some teenagers totally get it, and they will say things like, I understand this is really hard for my parents, and I would be worried too if I were a parent. But other teenagers, are not quite that insightful or mature in their thinking, and so they get very frustrated if they're with their parents questioning or not quite being on board. It's also really important that mental health providers that are trained to work with youth and families are actually that it's mental health providers that really can do the therapy and assessment. And so as the OHSU group has talked about, the mental health people need to be involved in the process. And again, parents are really grateful when they are able to be a part of the process. And that's all I've got.
We just have one last section.
Yeah, there is one last section. So let me hand it over to Dr. Connelly. There we go.
Yes, so before we're going to go on a break soon, and then we're going to do our case discussions at the end. But before we leave you with a break, I wanted to build off of what Dr. Edwards-Leeper was talking about some myths that sometimes families bring to our clinic. And being a parent is hard, and for all the reasons we've all discussed, this is very challenging for parents. Oftentimes more so than our adolescents, which is why although we're working on getting a teen social group going, we've prioritized the parent social group to provide support that they often don't get in the community, whereas our young people are in Discord servers that I just learned what that means, and other online spaces where they're talking to other trans youth, and our parents sometimes don't have that same connection and are trying to find information where they can. So it's very natural that they come to us with these concerns. So I'm just going to go through a couple, just briefly, what some of the things that we sometimes say, and recognizing that a lot of these questions are not coming out of nowhere. They're coming out of a place of care and concern and love. Okay, let's go to the first one. Is this just a phase? Yeah, we get that question a lot. These are just like quick tidbits that you can put in your back pocket. This is obviously a much longer discussion that you can have with a family. But something you could say is that if an adolescent is in puberty and has expressed their gender identity for more than 6 months, it's often not a phase at that point. As several of us have mentioned, prior to puberty, gender diversity and variance is very variable, but after puberty it becomes a lot more stable. So you might say, however, adolescence is a time of identity exploration and experimenting with expression. By supporting our young people in their gender identity, we can help facilitate healthy explorations of all aspects of their identity. What if they change their mind? I know I did. We evolve over time in a lot of areas of our identity. This is not something we see a lot of change in after puberty, like I said. So you might just emphasize that by taking a shared decision-making approach, you can help the youth make the most informed decision based on multiple perspectives and knowledge. Regret is rare, but there are no guarantees, and some people do experience regret. By approaching this as a team, we can minimize that risk by having the parents actually be active participants in helping their kids, because they know their kids best and know how to communicate with them and how to explain things to them. Next. All their friends are gender diverse. Could this just be a trend? Yes, many youth are exploring their gender identity and expression in new ways than ever before. However, not all youth feel distress related to gender incongruence, nor do they all desire medical interventions. So this is an opportunity to listen to the young person and learn about their specific needs without assuming that their experience is the same as their peers. Next. They think this will fix everything in their life, and honestly, this is technically, the slide says myths, but we do encounter some adolescents who think that, you know, gender affirming care or hormones are going to fix all the things in their life, and that is just not necessarily the case. As Jess always says, the world is not yet worthy of trans people, and taking hormones is not going to fix that. So we have lots of conversations with our youth about expectations and what they can and cannot achieve. But something easy to say might be that it's important that youth have realistic expectations. We should all continue to emphasize this and to facilitate the best outcomes. But there weren't any early signs. So this is often an opportunity to talk about the development of gender identity and the different common pathways that we see. So not all youth demonstrate gender nonconformity from a young age. It's actually common for youth to recognize and or disclose their gender identity following the onset of puberty. By coming out now, the young person is sending the message that they want the parents to be part of their journey. And that's one of the important messages we always emphasize, is that someone could wait till they are 18 to come out. Often they do. We at OHSU have the privilege of working with a lot of adults because, you know, we have all these surgical specialties as well. And we know lots of people who had to wait. And so we know that when youth are coming out in adolescence, that they're asking their parents to be there with them and to help them through the process. Next. They will have such a harder life if they are trans. This one really gets at me because it's often coming out in that expression of grief and what we call ambiguous loss, because it's not a grief of, for example, the death of a child, but there are losses involved for parents of how they saw their children growing up, their things that they imagined for their children in the future, and thinking about how the media, and there is a problem with violence against trans people. The media does exaggerate that problem and make it even more scary to seem than it actually is, but there are real physical safety risks. But that doesn't mean that somebody should make a choice to remain in a gender that doesn't feel authentic to them. So I often say that there may be challenges, but you know, the parent support is the most important protective factor in their life. So by having their parents with them along this journey, that is going to absolutely have the best long-term outcomes. And we see our youth thriving as they go on, and we know that it has much more to do with the fact that they had a family that was supporting them and helping them navigate healthcare and all of those things, even more than anything we can do in our clinic. I don't think I had anything else, but I can't remember. Oh, here we go. One more thing I put on here. So all of these, I think, come with this question of, can't we just wait and see? And this obviously is a theme throughout this presentation, but doing nothing is not a neutral option, and it has its own risks and benefits. The best thing we can always do is to listen and hear what youth are telling us and approach every decision as a team. The right time for any particular option will depend on individual experiences and unique goals of each youth and their families. I think that's the last thing I put on there. So I think we're actually a little bit early. Do we want to open it up for questions for the next 6 minutes?
That sounds like a good idea. We have several questions. So let's, we have some for everybody. They're asking, this one is for Jess. Can I get brochures, informational pamphlets for my clinic? Can you share resources, pamphlets or brochures?
Just to clarify, is that like brochures about our program or more like the social resources?
I think they are asking
or
about
the sexual health
the clinic.
stuff.
Yeah, because we just social resources. We just posted the links that were touched during the beginning of the day. You can find it in the handout section, and there's all the links there in their websites. Thanks. And if you would like brochures from the clinic, then just let us know and I'll pass it along. Thank you. Okay, next question. Is there anything you specifically recommend for helping create a safe space for gender diverse youth in rural settings?
My first thought would be if you know of folks who you're currently interacting with, to ask them directly, because in some cases folks want and need the same thing regardless of geography, which is a place that they can clearly identify, go to, know with some reasonable expectation that they're going to be treated in an affirming way. But others prefer that it's a little bit more, I guess, under the radar, so to speak, because then it's easier for them to potentially get to a place without being identified as walking into, that clinic that serves trans youth, or like the Coos Drop, one of the resources that I provided. We did one of our focus groups there, and one of the youths said that it was helpful to just say that, oh, I'm going to the Coos Drop, without saying, oh, I'm going to the queer group at the Coos Drop, in order to sort of get parental permission to go and be with people of similar experience. So, and then when someone does get into an environment, having a variety of artwork or reading material available that represents a number of different experiences and identities, and then thinking about how you as an individual signify that you're a person that they can talk to, are all sort of basic helpful tips. And then just know that if you build it, we will come. And word of mouth is the greatest source of information for trans folks, still, even with Discord servers and all that. That's how the information gets around.
Thanks. Next question. I've been avoiding diagnosing, so can you expand on appropriate diagnosis?
Regarding gender dysphoria?
Yes.
Okay. So I think it's important to recognize that in order to access medical care, a young person needs medical care for their gender transition. A young person needs to have the gender dysphoria diagnosis in their chart. And having that transparent conversation with someone, I feel is part of a trauma-informed practice, because then they know it's going to be on their chart, that they can access the care that they need, but it might be the paper trail that follows them, and that might out them in the future. In general, my rule of thumb is to not actually diagnose gender dysphoria or add it to a problem list unless someone has a stated goal to pursue some level of medical intervention, or if it is the singular focus of the work that I'm doing with someone. Again, recognizing that this person may travel around the country.
The microphone stopped working. Maybe we can go back to this question at the end when we can fix the audio issues. Let's move to the next one. And the last for this part was, what's the prevalence of gender dysphoria in childhood, and how much confidence do we have in that estimate? I think this one is directed to Dr. Edwards-Leeper.
Yeah, I went over this earlier with a couple slides, so I don't know if I want to take the time to say it all again, but the research is not good, and I'm happy to share the slides. I'm going to be sending those, and then you can maybe look at those, and that would answer that. But I don't want to repeat everything I just said earlier.
Perfect. Thank you so much. Right now we are going to go into break. I'll see you in 10 minutes. Thank you.
Testing my audio.
Yes, I can hear.
Okay.
Can hear
I
me.
signed out and signed back in, so hopefully that resolved it.
Okay.
And now you're having the scratchy voice problem again.
Yes, I think it's the microphone, like the little mic part on the
I
side.
literally use this every day, so I don't know what that.
I'm sorry, this program.
No, that's okay.
Can you try unplugging your headphones?
Try what?
I'm just unplugging them from the computer.
Oh,
No, no,
it went
I can't hear it at all.
Can you hear me now?
Yes.
Okay. I don't know what's happening.
I don't know, but it sounds perfect right now.
Okay.
So let's normal. Thank you so much. This program, maybe the audio, the connection, I don't know what's happening, but thanks for working with me to make it work. Thanks.
No problem.
Carmen,
Yes.
we're going to allow the participants to unmute for this next section.
All right. I'm unmuting them all. They all have the option to unmute themselves right now.
Okay, I think we can go ahead and move to our next section. And this part we feel is so important and helpful to kind of have an interactive discussion about complex cases, and is a lot more challenging to do in a web-based format, but we're hopeful that we will be able to stimulate some discussion from the audience. So when we get to the discussion questions, please feel free to unmute yourself and offer your thoughts and perspectives. So I'm going to turn it over to Jess to read our first case.
Okay, hopefully my audio cooperates. So we'd like to introduce you to Jasper. Jasper uses she, they pronouns and is a 13-year-old non-binary teen who was born with testicles. They present to clinic with a parent who's also non-binary. Her stated goals are, quote, I want tits and I still want my parts to work. The parent states there's a history of strokes on dad's side of the family, and counseling is provided on medical options, including pubertal suppression, androgen blockers, and hormone therapy. Non-medical alternatives, including breast forms and external erectile devices, are also discussed. And both the parent and Jasper report surprise upon hearing about the implications for fertility. After the discussion, Jasper expresses the desire to start pubertal suppression and eventually estrogen. We revisit the impacts on fertility and the ability to have erections for clarity and to assess the alignment with Jasper's goals. And Jasper's response is c'est la vie. Jasper's parent begins crying, stating that they had hoped to have biological grandchildren. And so on the next screen, we've got the questions. So what concerns, if any, do you have? How would you approach these concerns with the patient and with the parent? What is the role of the primary care provider in this case? And what is the role for a mental health provider in this case? And feel free to take yourselves off mute and jump in.
For those who don't feel comfortable unmuting yourselves, feel free to write either in the chat or question section.
So am I taking the silence to assume that, someone's unmuted. Okay.
Seems that there's a conversation to be had about shared decision-making regarding future fertility implications.
And any ideas how you would approach that? Would you do it with the parent and the youth together? Would you set up follow-up? Something else?
We have one response. In order to get them on the same side as much as possible, give them space to express themselves. You have to acknowledge the grief and loss the parent is expressing. The role for MH and PCP can be to help create communication and relationship between child and parent. That was by Catherine. Claudine says, give them a space to express what they feel in order to get them on the same side as much as possible. Then yes, and then talk about fertility exploration, set up follow-up for sure. We have Dana. She's asking for the clinic presentation. Sorry. And then we have another one from Brittany. It seems that Jasper is ambivalent regarding the impact on her fertility, and there are unknowns regarding her goals for potentially having children in the future. Shared goals need to be discussed for sure.
I don't know if I'm allowed to jump in. Oh, go ahead. You go ahead.
Sorry. And I think sometimes it just takes time on either one's end. Sometimes when that's presented, you don't even think of that right away. So even coming back to them at a later time and asking them how they feel about infertility, just because of that, you know, sometimes you didn't think about that, and then you kind of sit on that, and it needs a little bit more exploration later on.
And I'll just add that for all the information that gets exchanged in sort of social media groups or support groups, the fertility conversation does not seem to be the one that like is at the forefront of these discussions, and it is often kind of shocking to families when we do bring these things up, even though the information is very readily available on some of the leading websites like UCSF and things like that. But I think it's because it's such an emotionally charged topic and people don't know how to talk about it, as we've kind of touched upon in the hot topics area.
We have another answer. How much time do you give for the new information? And when developmentally can you think about fertility? This is from Hillary. We have another answer from Elisa. She's on the phone. The mute won't work. So they want to check in with Jasper in one-on-one session about the original reason for wanting their parts to work, and would keep the decision making out of that conversation for a few sessions.
Yeah, I just wanted to first say that it's hard for us not to be able to see you all. We wish we could see your faces, but all the comments so far have been exactly what we were hoping would come up during this discussion. Some of the things that and just to answer the timing question, I think that really depends on the individual and the family, and that's why it's important to assess sort of where people's attitudes and values are. The comment in the case presentation about wanting grandchildren, something that I often find with families is that might be something parents say at first, but it's less about their own desire for grandchildren and more about a grief about their child's loss of ability to have biological children. So sometimes getting at that can be helpful. We don't have enough research yet in this area. The little research that's out there, you know, especially related to this measure that I use on fertility attitudes, shows that generally people tend to be on more or less the same page, even if they don't think they are. But we need a lot more research. But we do pull from the oncology world a little bit to talk about these things with families. For one, in the oncology world, one of the biggest risks of regret of not preserving fertility among adolescents, you know, later in their adulthood, is feeling like they weren't involved in the conversation or feeling like decisions were made without them. Either way, so we really emphasize that no matter what age, even if it's not super developmentally appropriate to be talking about future family planning, involving our young people in the decision as much as possible is extremely important. And yeah, I totally agree with what the last person said about revisiting those goals around like the parts working, for example. and what that is, sort of what the function of that is. So for one family, it might take a couple follow-up discussions. For some families, we give them a lot of information and they want to take it home and discuss together, because that's where it feels more comfortable to have those discussions rather than a bunch of doctors, especially on a screen these days. And then other families need more follow-up to have more conversations.
I was going to add one thing. Oh, sorry.
Yes. Sorry.
I was going to add just one thing, that going back to the fact that we kind of turn to the oncology literature as kind of the only place really where there's the most research done on fertility preservation attitudes in youth. And I think one of the biggest distinguishing factors is the fact that in our situation, these are choices that young people are making, and in oncology, it's usually, their oncology treatment is not really a choice that they're making about the intervention that's going to affect their fertility. And I've had the experience with many of my young patients feeling really just expressing feelings of not only grief and sadness about loss of their potential loss of fertility as they are making the choice to start hormones, but anger too, and the fact, like, frustration that they're having to think about this and their friends are not. And I think that is in particular for the young patients who are started on pubertal suppression early in puberty, these feelings aren't going to be evident at that time that they're started on pubertal suppression. They begin to emerge as they're entering adolescence and are thinking about starting hormones. So I think that having these developmentally appropriate conversations at those different time points are really important and valuable.
Thank you. We have one of our audience members have been trying to get her mute microphone to work, but it's not coming through. So Diana, if you can please write down your question. We can see that you want to ask a question, so please write it down for us. We have another one, participation. It says, I'm not remembering all of the details of the case, but I was struck by the difference in the reactions between the caregivers and would think about how to engage them in processing them so they can best support them. When there is such a contrast, would you try to speak with each caregiver individually or together?
I can.
No, you go ahead. I don't want to dominate this.
It's fine. I mean, I think every case is different from my perspective, but I definitely think that there are times when it can be extremely valuable to meet with parents individually or caregivers individually. If they're on really different pages with things or having, because if you think about, each parent, each caregiver has had their own experience growing up with their own gender identity development and their messages that they receive through their life. And so I always tell parents it's very rare actually for if there are two parents or more parents in the family that for all of the parents to be kind of moving through the process and at the same speed. And so really normalizing that it's okay and fine if they're not at the same place at the same time. And then, really just working with them individually. And so my approach is, as the therapist, the mental health provider for the young person, if it feels like, the parent just needs a handful, parent or parents need a handful of sessions, to kind of get them on board, help them understand more about what's going on for their child, I feel very comfortable doing that. However, if they need more support than that, like ongoing therapy, either couples therapy or individual therapy, then I try to find them someone that they can meet with separately to deal with their own grief and loss process, or dealing, like with the fertility stuff. If they really need more time to process it, which a lot of parents do, it can be very helpful for them. Or connecting with a parent support group can be another great resource.
Thank you. Another one. It says in the future, they're asking if you can please leave the cases a little bit longer in the next one. Okay. So that's it for our.
Yeah. Okay. And so this is Aiden. Aiden uses he/him pronouns and is a 16-year-old affirmed boy who was born with ovaries. He's navigating care on his own and states that his parents are aware but are not supportive of his transition, and that they've stated that God doesn't make mistakes and that he will always be their daughter. He's on his mother's insurance. He has a part-time job at McDonald's in a rural town and no longer attends school because he was bullied. He sees a therapist twice a month for depression and PTSD. The therapist has been unsuccessful at getting parents involved in family sessions. He reports that he's known who he was since he was 8, but was only able to verbalize it at 15. He wants testosterone and top surgery, stating that he pictures himself with a deep voice, facial hair, and a flat chest in his adult life, and so that he can be safer and pass in his community. He requests an expedited surgical consult so that he can have surgery next summer. He's no longer able to use his binder because of pain and difficulty breathing, and he has an Nexplanon implant but continues to experience spotting and mood lability around the spotting. And it's going to be the same questions. So what concerns, if any, do you have? How do you approach them with this patient? What's the role of the PCP, and what's the role of mental health?
We do have one question. The case says affirmed, but not supported by the parents. Could you clarify what affirmed means in this case?
Yep. So he has recognized himself as a boy, as a man, and is living in most areas of his life with that identity affirmed, though his parents do not affirm that identity.
I do think we're picking up on some audio, so if you're unmuted and don't want to say something, please mute. I think I just interrupted somebody who was going to say something though.
That's okay. I was going to ask a question. Because his parents are not supportive of the transition and he's on his mother's insurance, does his mother have any legal control over his medical choices in this case?
No legal control. However, most 16-year-olds don't have jobs, so there would be a concern about financial responsibility, which is often where parents are able to exert their control in this case. Because of the changes that have happened to the Affordable Care Act, it's no longer required that parents insure their children. So she could potentially drop him from her insurance during her next open enrollment period, in which case, we would be helping him to try to get onto Oregon Health Plan. Because for those of you who live outside of Oregon, Oregon Health Plan is our Medicaid plan, and it has some of the most comprehensive benefits for supporting folks with gender dysphoria in the state. And in some cases, sorry, go ahead.
You might be about to say this, but in Oregon, our legal age of consent is 15, but that's not the case in every state. So, if Aiden is in a different state, that might change things.
Yes, exactly. And in some cases, we're able to get minors onto Oregon Health Plan, even if they do qualify for commercial insurance, if we're able to demonstrate that there would be a safety concern were we to bill the commercial insurance and an explanation of benefits be sent home or something like that.
We have a couple of comments here. Can he get on testosterone at 16 without parent support? As the mental health provider, I would be concerned that if he got surgery, he would not be cared for after surgery or get kicked out if on testosterone. This is from Diana. Then from Claudine, can he get medical emancipation and would Medicaid cover it? From Kelly, attempt to get parents to meet with me alone to get a better sense of their view and what client is dealing with at home in terms of family dynamics and stress. From Kelly.
We can answer some of the, questions that you listed.
Okay, let me see if I can remember those. Unfortunately for me, I'm the one that gets to talk about insurance all the time. So technically, yes, in the state of Oregon, a 16-year-old could consent to their own care. Our practice is to make every effort to get a supportive adult on board, or even an ambivalent adult on board, and work them to the place of being supportive. You know, if we were to move forward with someone like Aiden, it would not be lightly, it would not be after one visit. And we would want to have really clear conversations about safety, about contingency plans. If, you know, the parents did find out and his safety was at risk, or he lost his housing or lost his insurance, you know, thinking through those situations. And then for surgery, you know, that is an excellent point, that we would be concerned about his post-op care plan, especially because he may live some distance away from not only our center, our hospital, but any medical clinic in general, if he's living in a rural area. And so that would be something that we would work with him to develop, thinking about other supports that might be in his life, and trying to get creative to make that happen. And then again, there's that question of the financial responsibility, because he would have to claim his parents' income for any sort of financial aid application through a hospital system. And with a part-time job at McDonald's, he's not likely to be making the level of income to pay for a co-insurance on commercial insurance for surgery. Medical emancipation is less of a concern in Oregon because of our age of consent, but there have been situations for folks in like Washington who have gone through that process. And I can think of one young person who went through a formal legal emancipation process because of a number of reasons, but the parents were very unsupportive to the point that this person dropped out of school and was living independently by the time they were 16. So
Did
that answer all the questions that came through?
Yes. Now there's another one from Brittany. Aiden sounds exactly like a patient I'm working with. I'm also in a very rural county in Oregon. For my patient, his PCP has been very helpful with regards to education of biomedical changes of gender-affirming therapy, while parents are very opposed. My questions would be, will Aiden continue living at home? Is that an option? Will Aiden continue next plan on, or does he want a different form of birth control that will more effectively change mood liability?
I can speak to the second part of the question. So again, the next one on is a progesterone-containing implant that was originally designed for or developed for contraception, and is effective for 3 to 5 years. Unfortunately, there's a very high rate of breakthrough bleeding or ongoing cycles or spotting with Nexplanon. I think I've heard from my adolescent medicine colleagues up to 80%. of individuals who start. Now, if someone's also on testosterone, those two things can work together to make that less likely. But we do still have a lot of patients who have breakthrough bleeding and ongoing cycles with Nexplanon who are on or not on testosterone. So that is not my favorite intervention. When we're thinking about different, what we're using to suppress cycles, we also want to consider whether they are wanting contraception as well. So that's why, often Nexplanon is chosen because it's a great long-acting contraceptive. But if he has the Nexplanon and he has breakthrough bleeding, it's a common scenario that we run into. There's several different options. One is that you can add oral progesterone, the pills, the norethindrone acetate that I mentioned earlier. It's a daily pill that should be taken at the same time every day, and that can sometimes be enough to suppress cycles. Sometimes testosterone, again, if he's on the path towards starting testosterone, if we've done all this background work that you all have commented about, that might be something that can change that frequency. There's sometimes folks also start a combined oral contraceptive pill that have estrogen and progesterone in it, with the Nexplanon still in, and then there's also the option to have the Nexplanon removed and use a different intervention.
Thanks for the answer. Next question from Lori. Is he self-guessing for binder fitting? Perhaps he needs some guidance on proper fitting. I think maybe that's a self-answer question. Next, from Sean. What requirements, if any, do you seek to reduce issues for other MH? For example, depression, PTSD, before, with treatment for gender dysphoria?
Maybe just circling back to the first question about binder fitting, that's a really good point, because a lot of people, if they get a binder, especially if they don't have parent support to help them get one, they might get one that's cheap on Amazon that doesn't have proper fitting, and that could be some of the reason that he's experiencing pain and difficulty breathing. We often recommend brands that will allow you to send in exact measurements. But unfortunately, those tend to cost more money. There's also, here in Portland, this is not a resource everywhere, but we have certain stores who will do after-hour fittings for our adolescent patients where they can schedule an appointment to actually get a binder properly fitted. And then I forget who's mentioned it at this point, but for some people with certain body types, the binders, just even from the really good companies, are not right for their body type. And in that case, we might recommend something like trans tape, because if the binders are causing a lot of problems, and it doesn't say it here, and but if they're thinking about top surgery in the future, we want to make sure they're not causing any bruising or sores or anything. So that's really important. And then my working memory stopped and I forgot what the second question was.
When and how and in sort of what order do you address co-occurring mental health stuff alongside of or independent of gender dysphoria? Something along those lines.
Right, and I'll say a little bit, and then Dr. Edwards-Leeper might want to add to this, but we very much take a simultaneous approach when appropriate, like if it's appropriate to take a simultaneous approach to not put unnecessary barriers on when somebody can work on one or the other. That doesn't mean we want to hurry up and treat gender dysphoria and ignore the other problems, or vice versa. We very much want to make sure somebody's getting the mental and physical health support they need. Oftentimes that is a lot of figuring out how a person's mental health problems are manifesting in their life and how those manifestations might interfere with any treatment. Like someone who, despite all our conversations, their level of depression is really not allowing them to feel those realistic timelines for how long hormones take to work. Or, if somebody is having a lot of impulsive cutting in their chest area and how that might impact like preparing and recovering from surgery. Or so, you know, we don't have any sort of set guidelines for this needs to happen in this order, but knowing how those things interact and trying to make the best treatment course for both things is generally how we think about it.
Thank you. Oh, sorry, Dr. Edwards-Leeper, you're gonna answer.
Maybe I'll just quickly add. I mean, I agree with what Dr. Moyer just said. I think that, you know, every case is really different. I do find that this is where an assessment is super helpful to really understand sort of where the mental health issues are coming from, if they preceded the gender dysphoria, how they're tied to the gender dysphoria. Sometimes people experience gender dysphoria for other reasons like trauma or other kinds of mental health stuff. And so it can be really important in some cases to really get that all teased apart, to understand how possible autism fits in with all of it and all of these things. So I think it can get pretty complicated, but in some cases, it does make sense from my perspective also to kind of do both at the same time, but we just have to be really thoughtful and cautious.
Thank you. Our next question from Kathy. If he's not going to school and it's only 16, can the school system intervene? I wonder if they could compel, support the parents to participate in his therapy or provide some resources. Also, I would be concerned about whether twice-a-month therapy is frequent enough for him.
On the first point, I think this really differs across states. Like when I worked in Texas, you know, if a child missed 2 weeks of school, that like it was a whole thing. And in Portland, that has been super spotty. So I don't know how much the school system does intervene in these cases. Jess might know a little bit more about that. And then I completely agree that this sounds like someone who could potentially benefit from more frequent therapy. The problem we've been running into is that there is none, and there's nobody that has openings. And sometimes people are saying, well, I see them, you know, every couple of weeks because that's the only spots that they have available. And then we can supplement that as much as we want to, but we have to still work within the constraints of the actual world we live in and the mental health pandemic that's happening right now.
I mean, in this case, I would be hesitant to think that the school would do anything. I mean, this is a composite case, but for folks who dropped out of school because of bullying, it was often because attention was brought to that, to the staff or the administration, and nothing was done. Or in fact, the staff were part of the crowd that was bullying, or at the very least misgendering a youth. So yes, technically I think schools could report to DHS, but again, you know, DHS is not likely to even take that case up. And I'll be honest in saying that there have been some situations where we've made a report on essentially medical neglect if a parent is not following through on the treatment recommendations we've made regarding supporting their youth moving forward, but it doesn't go anywhere. So our systems are failing our kids across the board and not supporting parents so that they can support their kids better. And so then it leads to sort of this patchwork and where we're having to think creatively about how to support someone where they're at and just like try to get them to the next step and get them into adulthood where they have a little bit more control.
Thanks. If anyone wants to add to all of these, I can move on to the next question. Okay, how long is it safe to continue oral progesterone or combination OCP with Nexplanon? From Catherine.
That's a great question, and there isn't any research to back an answer. I think that there isn't any research to say that there's any harm to continuing oral progesterone. Sometimes it really is just needed temporarily to kind of stabilize the endometrial lining, and then they can, you know, be just on the Nexplanon that can be attempted. So I'll sometimes, basically when I prescribe the oral progesterone pills, I'll prescribe one pill once a day. I use the norethindrone acetate 5 milligrams. And if they have bleeding, then I have them increase to one pill twice a day until the bleeding stops, and then go back to one pill once a day. And I'll usually say at least a month to be on that dose of with no bleeding before trying off. But I have some patients who are on it for several years with or without testosterone or other medications, and there hasn't been any research to suggest that there's any harm to doing that.
Thanks. If there's anything to add, if there's nothing to add, then I'll move on to Gary's question. Based on what you have said today, probably a conversation about realistic timeline for surgical consult and surgery.
Yes, we agree.
And that was the last one that we have for this section.
Okay, we'll move on to the last one then. Okay, so case number 3 is Rose. Rose uses she, her pronouns and is 17-and-a-half-year-old affirmed woman who was born with testicles. She comes to clinic with both of her dads. She says she wants to complete a full medical and legal transition, but she feels hopeless about ever passing as a woman and sad that she did not come out sooner, so blockers could have helped more. She's been diagnosed with autism and ADHD, but no longer sees a therapist. She reports a network of online friends, but rarely leaves the house. She attends online school and spends the rest of her time gaming. She endorses a clear goal about being a mother, but feels like fertility preservation will further delay her transition. The PCP made the referral, but told the family otherwise, we, quote, don't do that here. The family is concerned about helping Rose meet her goals before adulthood, her safety in their local community, her isolation, and finding a local care team that is affirming. So again, what concerns, if any, do you have? How do you address these with the patient and with her parents? And what's the role of the PCP and what's the role for mental health in this case?
So I would just like to make a comment, Declan, here, and it's not particularly about this case, but another question just from the mental health provider's perspective, that we're still having to provide these letters and feel like we are the gatekeepers. What's the progress in that changing from in the medical field where these letters won't be required anymore?
I can speak a little bit to the standards of care, if that would be helpful. I can't say a whole lot, unfortunately. I wish I could. It would be really great to be able to share a lot more. But assuming nothing changes from now until when it's published, I think that the assessment process is still for youth going to be strongly encouraged whenever possible. It's just seen as a really critical component of individualized care and developmentally appropriate care. So in terms of the letter, I think that's sort of up to what the clinic wants from providers in the community, a letter versus a report or, or communication directly from the mental health person. But I guess that's what I can say just in terms of properly assessing all of the points that I made earlier is going to still most likely be a critical part of the standards of care.
And from our perspective, I saw Danielle starting to talk. From our perspective, we don't care what form collaboration and communication comes in. Unfortunately, insurance is what drives a lot of our practices and needing to ask for this letter to submit in order for someone to get coverage. And we continue to try to advocate, especially around puberty blockers, because of the critical periods, and have been successful with some health plans to sort of get that waived. And then, you know, we've continued to advocate, but the insurances tend to dig their heels in, so that there's a paper trail that they can turn to if there was some sort of, I guess, liability or accusation or something. So, and Danielle, do you want to add anything?
I was just going to add that, you know, it is hard to fight history and the historical sort of gatekeeping model. But in the world we live in, where insurance requires the letter specifically, you know, we wouldn't mind if you just, like Jess said, called us and told us about your assessment. But insurance will require that documentation. So what I try to do is work within this system, right? Like, how can I know this has to be a part of it. So how can I use this to best help the family? And sometimes that means, you know, if I was working outside of the team, but I was referring someone, I could use the letter to really communicate important information to the team that they might not otherwise get. Or, you know, sometimes assessment reports, we use those therapeutically, right? Like feedback can be therapeutic in any psychological assessment. So using how we write that letter to sort of guide the family. Sometimes, you know, even when it's very clear that somebody's consistent in their goals, but parents are really still struggling to see it as something that's going to be legit, like having that documentation can actually help them feel more comfortable that process is gone. And sometimes that physical documentation helps that feeling of like, okay, we did the process. So I would just recommend, you know, whatever system we're in, however the standards evolve over time, being just how can we use that to facilitate rather than be like a specific barrier. And that's why I say anytime a young person asks for a letter of support, if you don't feel comfortable with that, not just saying, I don't feel comfortable with that, like reaching out to us or somebody else to find out how you can be a part of that so that it doesn't become, oh, I'm creating a barrier. Like how can we be the facilitators?
I was just going to add one last thing. We find that sometimes the whole like letter thing can be a barrier to the kids not getting medical interventions, but like accessing mental health support that they need. If it's somehow viewed or conveyed as like a checkbox, like you have this letter in your hand, but it's not actually saying anything about who that young person is or what their environment looks like and what conversations have happened and what are any risk factors we need to be considering. And as a medical provider who prescribes medications, all those things are so important. And so we can't just rely on a letter that just says this person, you know, I'm writing this letter so that they can start medications. I think there's just so much more that goes into the care that these patients need. And that's why we are, I say we, but it's Dr. Moyer and Jess who are in very frequent daily communication with community mental health providers so that we can fully understand holistically who this young person is and what is in their best interest at any point in time.
And I'll just add 2 more points, one of which is the way that historical trauma sort of handcuffs us as mental health providers too, because everyone is so focused on this idea of a letter, and it doesn't necessarily allow for the space of really authentic communication and an exploration, because most trans people feel like if they show up with any amount of ambivalence or fear or whatever, then it's going to result in not getting a letter or having to go through 6 months of therapy before they get the letter. And so anyway, that's just something to consider, and consider if you are being asked to write these letters of support, how you approach framing that conversation so that it is actually beneficial for the young person. I'll kind of leave that there. And then thinking also about that, going back to that idea of like how our commitment to trauma awareness has to happen on multiple levels. There are several Oregon Health Plan CCOs or coordinated care organizations that only contract with one behavioral health provider in a whole county or region, and then that behavioral health provider's leadership, for whatever reason, has said our staff is not qualified to write these letters because of XYZ thing, and then the youth in those areas are just completely out of luck or forced with trying to find the means to pay out of pocket. And so if you happen to be in one of those organizations or find yourself in one of those organizations, that's where the activism really does have to come in and start questioning the why, and pushing people to look at their practices, because it is an access issue. And it often means that people who are committed to providing affirming mental health care in those environments don't stick around very long, because they aren't able to do the full job that they want to be able to do. So I know that gets us off topic from Rose here, but very important question, Declan. Thank you.
Thank you. We have a question from Elizabeth. I would be curious about Rose's perception of her social isolation, particularly in light of the autism spectrum. Exploring positive and supportive online community connections could be particularly valuable, at least as a stepping stone to increasing social connection when she is interested. Another the comments questions comes from Claudine. This child is fortunate to have adult support. I would get started with a comprehensive assessment. And another comment from Catherine. I find fertility preservation so difficult because of the cost related to it. And from Claudine again, needs MH therapy to explore grief over time lost if the PCP is not willing to help with the team, setting realistic goals, plan of care, prioritizing next steps.
You might be able to pause there for a second.
Oh, yeah.
Yes.
I was just going to quickly address the cost of fertility preservation. It is a huge problem and a huge barrier because it's not covered by insurance and should be. And so for those who are pursuing sperm cryopreservation or freezing sperm, it's a lot less invasive and less expensive than those who are pursuing oocyte or egg preservation and retrieval and preservation. For those who are pursuing sperm cryopreservation, it's I'm trying to remember off the top of my head, and maybe my colleagues will be able to correct me if I'm wrong, but I think it's a $500 cost for the initial sample to be tested, and then I think it's about a $300 annual storage fee. So we do have a number of patients and families who are able to afford that and pursue that. But there's also the complicating factor of how the sperm sample is retrieved, and if youth don't feel comfortable engaging with that part of their body, it may be a really big barrier to them being able to produce a sperm sample by ejaculation, masturbation ejaculation. There are some more invasive techniques that can assist with ejaculation or using basically not a biopsy, but being able to retrieve sperm with a needle, essentially.
The most recent estimate we got was 400 for the first year to store, and then 250 every year after that. Not that the exact numbers matter, but it is a little more affordable to families than the egg preservation. And I was just going to also comment on the question about the importance of social groups and the online groups, and we find that so helpful for our teens and young adults to connect with people. And it's interesting because I think, you know, we're in a pandemic, so we're all doing everything virtual right now, but the LGBTQ community has historically found online spaces and made really safe online spaces in the past. So I think that community was already poised to do that. And then some of our groups, our local groups, have gone online too, and that's been helpful for our teens as well. I don't remember any of the other questions.
There were mostly comments, and both of them were about social, and I think you've covered them. Thanks. If anybody wants to add anything or ask another question, please do. Otherwise, I think we're done with the case discussions part.
Can I make a comment?
Yes, of course.
I work in a rural medical clinic and have encountered PCPs who are extremely religious and would refuse to do any interventions with an adolescent. And at times they might make a comment like that, we don't do that here, when that's not the policy of the healthcare system. And they don't actually know the opinions of their other PCPs in the same clinic. They haven't gone and asked them, they haven't gone and talked to them, so they're making a global statement, and that's not necessarily based on any fact. So I would encourage them to potentially explore one of the other PCPs in their local clinic, because that person's statement could be completely inaccurate.
Thanks for that comment. That's a really, really helpful point, and it reminded me of something that when we often will hear that, you know, we sometimes will try to arrange the pubertal suppression injections to happen at the PCP's office, and that's because insurance requires it to happen there, you know, based on their benefits, or if it's, you know, if they live 3 hours away from Portland, it's a lot more convenient and accessible. Other things that insurance and Medicaid or Oregon Health Plan requires that the PCP be the one to put in referrals for surgery, for example. So we've had PCPs that will just tell our office nurses, we don't do that, or we can't do that. And what we will do as a team is to try to reach out to them to find out what the reasons are behind that. And most of the time it's just misunderstandings about what is actually necessary and what the role of the PCP is, and that we'll be the ones that are prescribing these medications and doing all the prior auth and everything. And really it's just their staff that's going to be giving the injection, or in terms of requesting the the surgical referral is because it's an insurance requirement, but we are doing all of the counseling and preparation of the patient and assessing if they're ready to move forward. So we really try to have open dialogue with providers that have questions or concerns or hesitations about providing this care.
And I'll jump in to piggyback off of that. You know, after exhausting the relationship building options, many health plans, commercial health plans at this point, have like trans health coordinators or liaisons that can be contacted to file a formal complaint. You know, insurance companies drive the networks that their members are able to have, and if there's a specific clinic that has a repeated pattern, money talks, frankly. And then in Oregon, the Oregon Health Authority has ombuds people who can step in some cases with clinics to be a more neutral party, especially if they're a Medicaid accepting clinic. And then in Oregon, we have the Oregon Insurance Division that has been very clear about non-discrimination in healthcare, and they have stepped in some cases as well. So there are options, even if the sort of relationship building doesn't end up being as effective as we would hope.
All right, and now during this part of the session, I'm gonna start sharing my screen. So please write down your additional questions on the question box, like you've been doing so far. In a minute, we're gonna be answering all of the remaining questions and the new questions that you might want to add. Now, thanks to our presenters for all this wonderful information. To our audience, please write your questions while we go over some things to remember. First of all, this is the activity code for today's webinar. Please write it down for your records. It will be included in the email, in the follow-up email that you'll be receiving later today. You'll need to set up an account or log in into www.eeds.com and enter the code 09BREN to be able to claim your credit. Things to remember after the webinar. Again, you'll receive an email with the instructions on how to get your certificate, what was the code, and how to watch our recorded videos via the Oregon Pacific AHEX YouTube channel. Your feedback is valued, so please complete the program evaluation when you claim your credit. It'll take just a moment and it'll be of great help to us. The activity code expires in 1 week, and the webinar is being recorded, and the recording will be available on the Oregon Pacific's AHEG YouTube channel. We're gonna work very hard to have it posted today, but if you want to watch it again, I would say please look for it on Monday. And finally, feel free to reach out to the Oregon Pacific AHEG if you have any questions or concerns. We'll be happy to forward any questions to the respective panel or panelist. And now let's go over your questions. Number one, the first question that we needed to answer is from Seth. The year of therapy always felt to me part of the relic of deprogramming and really concerns me. Any insights?
Right. Hopefully that was clear that there are no longer length of time requirements in therapy. There are some surgical procedures that require a length of time on hormones, but the mental health component is no longer time limited.
Oh, perfect. Next question from Christine. If youth are presenting in a court context for the first time, what do you think about asking for name youth would like to use and pronouns at that time? We have been exploring these and have to balance affirming without presenting youth with an additional tension, possible first stating it in front of family or having a non-unsupportive or rejecting family system in an already tense moment. Legal names is often present in this hearing as well.
So I've done some consulting with Multnomah County, and what they have sort of adopted as a practice is that the judges call the young person, and the young person is prepared ahead of time by their attorney for this, but they call the young person up to the stand essentially and have a sidebar and say, you know, this is a legal proceeding. We typically use legal name. What would you like us to use today? The attorneys can also clarify that ahead of time and then submit that. But I wouldn't just globally say across the board, yes, absolutely use someone's affirmed name and pronoun every time unless you know that the family is aware and that it would be a safe thing to do so, but allow for the opportunity.
This is sort of a side note to the question, but I think it's really easy to make assumptions about things too. Even myself, I assumed like our IRB would require sort of legal documentation, and I reached out to them and learned recently that there's no requirement for someone to use their legal first name on a consent form for research at OHSU. So I think just, knowing what your institutional requirements are and then checking in with individual families about their preferences. This is outside of the sort of courtroom, but yeah, just not making assumptions.
Thank you. A quick reminder that yes, we're going to make available all the slides. If we don't have, if we are not able to do them right now in the handouts, we're going to be able to send them to you via email. Next question from Sean. So, in light of the cons of social transitioning, would you recommend to parents to simply call their child rather than gender specific, like son or daughter?
I can say something about that. I think it really depends on the situation. I mean, in some circumstances, it's absolutely appropriate and most affirming for the kid if they've socially transitioned to use the terms that the kid is asking for. But in some cases, the kid isn't really asking. I've had kids who use she, her pronouns in one setting, he, him pronouns in other settings. One young, like 5-year-old, I always use this example because it's so cute, said that they see themselves as a boy on the days that it rains, and they see themselves as a girl on the other days. So, I mean, for younger kids, there can be so much variability. And so in situations where the kid is maybe identifying as more non-binary or sort of in the midst of exploring and sorting it out, then maybe, using more neutral terms like child, I think is a great solution. But every situation is kind of different. And I think this is where it can be helpful to, have professionals involved who are familiar with working with gender diverse young children to sort of help the family navigate what makes the most sense at that moment in time for that particular child. Because I have had a number of parents come with their young child thinking that one thing was going to be the best based on stuff they read online or parent support groups they went to. And then after doing an assessment and kind of me meeting with the child and meeting with the parents, turns out that, it's a very different plan that's really that everyone agrees is going to be best. So I think involving professionals can sometimes help sort some of that out for the individual family.
Thank you.
And honestly, I'm a big proponent for offering that question to any child in a family system, regardless of gender identity. Again, a lot of times these questions get proposed to gender diverse youth only, and it can benefit their cisgender siblings. There might be, a sibling that doesn't want to use the term daughter and would prefer child, but there's no other sort of gender diversity to their experience. And yeah.
Thank you. Our next from Teresa. Does a youth have to have a gender dysphoria diagnosis to receive medical treatment?
Unfortunately for insurance coverage, that's the diagnosis that is needed and used to get insurance coverage, yeah. At this point.
What I'll just add is that the ICD-10 is changing their language, ICD-11, whichever the next ICD is, from gender dysphoria to gender incongruence. It's a small change, but it's coming down the pipeline.
And I think the one exception would be for the cycle management options, because those can be billed under birth control or other diagnoses that I won't make up with my my Grey's Anatomy degree here.
And the spironolactone as well. So it's used for other indications. It's actually a blood pressure lowering medication.
Our next question from Diana. If there is time, sorry, can you talk more about no complicating mental health concerns? Most kids I see are also dealing with depression and anxiety.
I can maybe say for a minute, I think we're close to the end of our, I can't remember what time we end, but it's hard to cover that quickly. But as I said before, you know, I think it's important to take the time to sort out, to, you know, through, you know, therapy, assessment, whatever it is, where the, like how the gender identity and dysphoria started, and getting that info, you know, getting the story from the kid, of course, but also from the parents, getting a comprehensive mental health diagnostic assessment, just, you know, do that so that you really understand the history of the mental health issues, that's the family psychiatric history, all of the things you would always do with any child with mental health concerns. You know, you want to understand where it's coming from, in part because if it seems like the mental health issues predate the gender dysphoria, and so you can be fairly certain that it's not just from the gender dysphoria, then the child might need medical, like psychotropic meds or something like that, or more targeted treatment for their anxiety or their depression. And it also is really critical that that's addressed and talked about so that the young person and the parents don't jump to have this expectation that once they start their gender transition, if that's their plan, the mental health issues are going to magically improve. I mean, they very well may improve, but they may not completely go away if there's an underlying, like if there are underlying mental health issues. So that's part of it. The other part of it is just, then I didn't get into this because we didn't have time, but just very quickly, there are some young people, especially during COVID, I have found who, you know, were very socially isolated and, you know, had increase in mental health concerns because of that, and kind of started looking online to try to figure out like an explanation for why they felt so alone or different or depressed or anxious. And sometimes they do, you know, stumble on information about being trans, and not always. I'm definitely not saying that this is always what happens, but there are situations when people think that that might explain why they feel different. And so it's important to tease that apart and to really help them figure out, is that an additional piece that they're just now learning about themselves, or is it like, are they confused and it's something that, you know, it's really like a trauma history or their autism or depression or anxiety or something like that. So it can be complicated and it can go either way from my experience. So I guess in a very short answer, that's what I'll say.
Thank you so much.
Just as a reminder, there's a lot of things actually that have changed in the pandemic, and we want to keep that into consideration. I think in particular, one of the unique things we've been seeing lately are trans feminine folks wanting to do a social transition and medical transition simultaneously. Because before the pandemic, they didn't feel like they could do anything. And now they're feeling like because things are more online, or because they've had a break from seeing their peers and all that social stuff that comes with it, that there are more opportunities for them. So I think, yeah, the pandemic is something we have to take into consideration probably for a long time too. Sorry, Carmen, I interrupted you.
Oh, it's okay. I was just gonna answer one of the requests. They wanted the activity code, and it's right on your screen. And I think with that, we are done for today. Please again, write down the code. It's right there on your screens. We have many questions unanswered. I'll make sure to get them to our panel as soon as the webinar is done. And I just want to say, please watch for the follow-up email. It will include the instructions on how to get your credits, the code, and the YouTube link. On Monday, I'll be sending you an email with all the handouts, and you'll be able to check finally for the video. Thanks to our speakers for sharing their time and knowledge with us. Thanks to all of you for participating today. And you have now completed the session and you may disconnect. Have a great day. Thanks to all. Bye.
Thank you.
Thanks, Carmen.
You're welcome. Bye.